Now coming to the physics, basically, this is a very dry area, so I expected less audience today. So we need to not only optimize the image, but when you optimize the image, you should understand that your examination time reduces. Once your examination time reduces, the confidence level increases tremendously. And of course, when you're using your equipments, please do not escape one major aspect of patient safety. They're making me look a little taller. So I think, anyway, okay. Now, this is a roadmap of my talk today. We have so many things in our equipment we need to do, starting from 2D to image display, to color Doppler, to pulse Doppler, to power Doppler, and patient safety. I'll be talking on image display. First of all, in the image display, when you begin your ultrasound, the first thing you pick up is I need interaction. You pick up a transducer. So you have multiple frequency transducers. Today, all your equipments are band choice. You have a broad band transducers where you have high resolution, normal penetration. So wherever you want to work, whether you're doing a superficial structure, you need a high resolution. Okay? If you're looking at a deeper structures, you need penetration. So you need to know what penetration is, what resolution is, what normal is, where is your optimum image. Second most important thing when you choose your transducer is you need to understand the habitus with which a mother is coming. A person like me, a thick habitus, you need to go in for a low frequency transducer. So, and gestational age. You have an advanced gestational age, a third trimester baby, and if you're going to use your high resolution transducers, you're going to scan only a 2 centimeter of the superficial part. You'll be just in the subcutaneous tissue and you'll not see anything what is happening to the fetus. Second is chroma. Okay? We understand in the human eye, in the retina, you have rods and cones. Okay? So rods are basically for gray vision and cones are for color. You have the density of the cones which are more focused to the fovea centralis, from where the visual acuity comes. So again, rods evaluate gray color, and visual acuity and resolution is much better with the cones. So prefer using 2D chroma. It not only relaxes your eye muscles, but there is less stress when you're using chroma. So lesson 1 is choose your transducer properly. Lesson 2 is prefer using 2D chroma. It relaxes your continuous day of work. 2D optimization. In 2D optimization, you have lot many things, but I'll be talking on frame rate. Now, what do you mean by frame rate? First, it is affected by the depth. Now, this is an image to show you increased depth and a decreased depth. When you increase your depth, that means the machine has to send certain ultrasound beams, and once those particular beams come back, and then the next set of beams are fired, the machine has to work more or less? More. So your frame rate would decrease, right? Vis-a-vis, if you decrease your depth, what happens? The machine has to work less. So your frame rate improves. And secondly, if you're using an increased depth, you're not seeing the area of interest. It is so small on your image display that you can hardly figure out what is happening. So you need a optimum depth. Second factor which affects the frame rate is the sector width. The width of the sector. You have the machine, you have something looking like that on the machine is the sector width. If you decrease the sector width from 58 to 27, for example, what you're going to do is, you let me know the machine has to work less. Your frame rate will improve. Vis-a-vis, on the other side, the machine has to work bigger sector, you have to work more. The machine has to work more. So your frame rate would certainly decrease. There are situations in obstetric practice where you need a higher frame rate. For example, you need to scan the cardiac, right? Where an obstetric Doppler, you need you have to optimize with a lesser frame rate because you need a wider angle. So this is an example to show you wide angle, more depth, lesser frame rate 48 Hertz, vis-a-vis narrow angle, less depth, showing you increased frame rate. Now you all do NT measurements. Do you do NT measurements? Okay. Do you zoom or do you magnify? Do you understand these two things? Okay. Is there any difference? Let me show you today. In magnification, when you magnify an image, what happens is the machine continues to scan the entire area and the frame rate remains the same. Okay? 21, 21. Whereas you zoom, the machine only scans the area of interest. For example, you're doing your NT. You need to zoom your head right? So you see, so remember, on your machine, do not magnify, use zoom. Lesson 2 learnt, don't magnify, zoom, keep looking at the frame rate. 2D optimization also includes, in addition to zoom, magnification and other things, you need to use tissue harmonics, SRI, CRI. These are the important constituents which are now available with good machines. What is CRI? I'm not going to make you bored with these kind of things, but I just want to tell you, in CRI, there are a lot of speckles. Speckles are artifacts, right? They have different, speckles have different scan angles. So now the speckles, I've showed it on an image, all these speckles are plussed up. So finally you get a beautiful looking image on the top. So with this better contrast resolution, border protection. So this is what a CRI is. Examples to show you fundamental.
देखो ये इसका हैंड माइक का ये है, इसका भी दबा हुआ PF है.
One line about 2D spatial resolution. Just you need to know that the axial resolution is the best. Why? Because the structures which are parallel to the ultrasound beam are visualized to its accuracy. So lesson 3 is use harmonics, use CRI and SRI. But remember, these reduce the frame rate. So everything you do on the platter, you have to weigh. So what happens is if you are getting a reduced frame rate, but you look at the benefit of the image quality, which improves and outweighs the reduction in the frame rate. So everything is not going to be the same. It's going to be a balance of looking at things. And axial resolution is better than the lateral and the azimuthal. Coming to color Doppler. Now, all examples I'll be showing you. This is an example to show you low color gain, where you hardly see any flow in the vessels. This is another high color gain. What is happening? You have a bizarre looking color inside the vessel as well as outside the vessel. So you need to have an optimum color gain where you need to have the flow within the vessel. So go in for an optimum color. Use 2D and 2D color Doppler for situations where you have a 2D abnormal. Another important thing is color balance. We actually don't go and see what is happening with the balance and other things. But I need to tell you, know about these things, you can understand your equipment better. You can modify these things to get your images better. And if your images are better, you can send these images anywhere. They are reproducible. You understand the concept behind image optimization. So coming on to the color balance, balance controls the amount of the color displayed over a B mode echo and helps to confine the color within the vessel wall. Now let's look at this example. If you have a balance of 170, you are looking at a VSD. Am I right? What about the other image? Are you seeing any VSD? No, you're not seeing any VSD. So that means if your balance is too low, if your color balance is so low that you're unable to look at the VSD, that means you're not doing justice to your equipment. You're not looking at things in totality. So you're going to misfire your diagnosis. You look at a VSD, the balance of 170, and the balance of 20, you're not going to see a size of the color pixels. The number of the line there says, number is the, you are going to, what you are going to do is, again what the machine is going to do, I told you in the beginning, the increased number of lines, the machine is going to work more, right? Larger the color pixels, the machine is going to work more. But you see the high resolution you are getting. The color resolution is so good, right? So another thing is ensemble. What do you mean by ensemble? Ensemble is the number of pulses for one displayed color line, right? You have a long ensemble and you have a short ensemble. Again, if you have a long ensemble, the machine is going to work less, right? So if the machine has to work more, your frame rate would decrease. Now let's look at this slide. So for color resolution, you not only require a high light density, you require a larger pixel color size, you require a long ensemble, which will give you better resolution, better color resolution. But your frame rate will be slightly less. So you're not getting everything again on the platter. What you have to do is, in such situation, for a better frame rate, please use your color box. The color box which you're using, reduce the color size of the color box, one. And secondly, again use zoom. So once you zoom and you use a smaller color box, you would get a better frame rate. So what frame rate which you were getting less because of so many things, better color resolution, we are looking for good color. So you can compromise that negative aspect by using simple things, zoom, do not magnify. Example to show you, optimum wall filter and increased low fall filter. If you have low fall filter, the color will flow over the vessel lumen. So color wall filters are, low wall filters are to be used when you are mapping your venous Dopplers, and high wall filters are used when you are mapping the arteries. Examples to show you low PRF. PRF is another modality, that is pulse repetition frequency. Low PRF, lot of aliasing. Ideal PRF 1.3 to 1.9. That's the ideal PRF when we are doing a obstetric imaging. So high velocity PRF should be used for cardiac imaging when you're looking at the fetal heart. A medium velocity is good enough for doing obstetric Dopplers, and a low velocity scale is ideal for doing your venous, when you're doing your ductus, when you're doing your umbilical vein and IVC. So lesson 4 learnt is keep balance 2D priority medium, use optimum color gain and quality, use optimum PRF. Coming to pulse Doppler. Pulse Doppler optimization, first is the gain. Many times you see such kind of image. Please avoid this. Your image of your pulse Doppler should not show background artifacts. This is just because you have increased your gain. Second, if you are doing your color Doppler and you have a side-by-side display, or even if you have a display which is down, you need to have an optimum length of the spectral waveform so that it occupies at least 75% of the screen. I'm telling you very simple things. Next, if you're using wall filter, is another thing on the machine. If your wall filter is too high, you notice you are going to erroneously make it as absent diastolic flow. You see on that side your wall filter is so high, you do not see a diastolic flow. So once you do not see a diastolic flow, a normal umbilical artery would show you an absent diastolic flow. Coming to Doppler angle. Ideally, it should be less than 30. In certain areas, like you're mapping up your MCA, you need to be 0. So you need to understand Doppler angle, which I think most of it you know about it. So lesson 5 is your angle of insonation, your sample volume size, your medium PRF, ideal for obstetric Dopplers. Wall filter settings have to be optimum so that you erroneously not diagnose that absent diastolic flow. This is what is called as Doppler Cross-talk. Avoid this. How to avoid this is, one is you reduce your gain settings, and second is you correct your angle. This should be avoided. Either you should have it above the baseline or below the baseline. Now power Doppler. It's an amplitude mode. There is no aliasing, no information on velocities. Whereas color Doppler gives you velocity mode. It is shows aliasing, and it is linked with the velocities. Coming to patient safety, that's the last slide. We need to understand the ALARA principle. There is something called as mechanical index and thermal index, which is shown above on the highest point when you're looking at your machine, shows MITI, right? So that is very important. It should be less than 1 for patient safety. Now when you increase the gains of the machine, how do you do it? Either you use your 2D gain, or you're using your TGC gain, or sometimes if you have a situation like this, the patient is very obese, 18 weeks, you're having a thick body habitus, sometimes there is a button on your machine which is called as 2D power. You can increase the power slightly so that your image improves temporarily. For this, if you notice, the temporary increase in the TA and MI are there, but remember, this does not go beyond 1.5. So this can be sometimes used to get an optimum image, to get information as quickly as possible, and then you can resort back to your routine imaging. So increasing power increases the strength of the ultrasound beam and also increases MITI, whereas increasing TGC gain just amplifies the received waves. There is no increase in MI and TI. We must balance between the resolution and patient safety. So finally, all the lessons learned are your transducer selection, use chroma, zoom, do not magnify, encourage your SRI, CRI harmonics which are already inbuilt, increase the line density, increase the ensemble, reduce the color box size to get a balance of a color resolution and a frame rate. Your pulse Doppler settings have to be adequate. Increase your color balance when you have low flows, when you need to detect small VSTs. Look at the TI and the MI, and rarely increase power of the 2D. So understand your machine, make your presets yourself. Thank you so much.
I think one can't overemphasize how important this particular talk is, because as you know, when you've been scanning and you're struggling with images and digital patients, really knowing your machine helps. I mean, I think the main question that people seem to have is that, well, does this only, can you only optimize images on the high-end machines, and what about the sort of medium and low-end machines? Because I know, being a sort of OB-GYN myself, we have no experience at all on how to, the physics and the radiology bit of it. And we really struggle with our images not being so good. But the main question which is asked is, well, look, our machine is not that great. We don't have the top-end machines, and that's why our images are bad. But I don't think that's particularly true.
That's not important, ma'am. Whatever machine you have, at least you should try to get the best out of it. It's only that we are not
I don't want this
knowledgeable about it. If we are knowledgeable, at least we can,
focus on
make the best use of it.
Yeah. So is there any question particularly that you all want to ask?
How many of you are doing ductus in the first trimester? Can you raise your hands, please? Do you have a preset which will give you gate of exactly 1 millimeter with 60 megahertz of a frequency and an angle correction which is 0? Have you set your machine? Probably no. So these are the presets, right? These are the presets she is asking for. Make a preset. If you are doing a first trimester ductus venosus, the moment you press first trimester and DV, this is the preset, it has to be there. You don't have to change it because it is mandatory. The second point, umbilical artery, if at all you are pressing umbilical artery at any point of time, the gate should be only 2 millimeter. Uterine artery again 2 millimeter. Except tricuspid regurgitation, where you will probably require 3 or 4 millimeter width of a gate, none of the preset will require 3 or 4 millimeter gate. Unfortunately, all the machines are set for 3 to 4 millimeter gate, isn't it? So make sure that the gate which is only 1 to 2 millimeter as per the requirement, and the frequency of that particular waveform is at 60. If it requires 60, then it has to be 60. PRF, you can prefix PRF also. So make sure these are the presets which Dr. Ladvans is talking about. So I don't think everybody is interested in making these presets. Because these presets are not that primarily we looking at a waveform which is there, a job is done. Actually it is not like that. At fixed points, these presets has to be made, and that is how it has to be traced, and that is how it has to be measured. So make sure that you can call all your company, whichever company machines you are using, call them and make fixed presets like this. Okay, so that is what Dr. Ladmans, am I right, Dr. Ladmans? Good, thank you.
You can further go and, if you have a fetal echo, you go to a fetal echo preset, right? So you should have everything, you should have a higher frame rate, right? So if you're doing your obstetrics, like sir has very rightly pointed out, we should make our own presets, because that means we understand, we can ask for that. We just rely upon these people who come to us and show our machines, and whatever they've done, we've said fine, because we don't understand. If we understand, we can demand. That is it. Thank you.
I'm going to, from the most important talk that Dr. Ladvans has taken just now, from the excellent talk, I'll just move on to a little more basic, which will be instrumental in forming the basis for all the subsequent talks for the day. So just a brief overview of the fetal circulation. We all know that, let's go back to physiology, first professional, that the functions of the circulatory system are to provide oxygen and nutrient supply to the tissues, adjust the oxygen supply to the metabolic needs of the tissues, and return deoxygenated blood and carbon dioxide to the organ of gas exchange. Now, the fetal circulation is different from the adult circulation because the gas exchange is occurring at the level of the placenta because the lungs are not functional. In addition, there is preferential streaming of this highly oxygenated blood to the myocardium and the brain, which does not happen in adult circulation. This is achieved by intracardiac and extracardiac shunts such that a non-parallel circuit is formed. So that is instrumental. So the gas exchange is occurring at the level of the placenta and not at the level of the lungs. So we all know from embryology that the left vein is left. So there is one umbilical vein and there are two umbilical arteries. Now oxygenated blood from the placenta is transported through the umbilical vein into the body of the fetus. Now there are three shunts in fetal life. The first one is the ductus venosus, which connects the umbilical vein, which is carrying the oxygenated blood, to the inferior vena cava. The ductus arteriosus, which is connecting the main pulmonary artery to the aorta, and the foramen ovale, which is the anatomic opening between the right and left atrium. Now, this is a diagram giving you the overview. We'll come back to this. So, the oxygen saturation when the blood is coming from the placenta is 80 to 90%. Now, 50 to 60% of this oxygenated blood will bypass the hepatic circulation via the ductus venosus, which is connecting the umbilical vein directly to the inferior vena cava. And it is such a small caliber vessel that the blood velocity is very high in this tiny blood vessel, which shows up as aliasing on our ultrasound screens. That's how. So from here, the ductus venosus is connecting the umbilical vein to the inferior vena cava, which is opening into the right atrium, and it is bypassing the liver. Majority of the oxygenated blood is bypassing the liver. So this is the most, so the umbilical vein, it is showing the pressure of the blood flow, the velocity of the blood flow. You can see that the velocity jumps to 60 to 80 centimeters per second because of the low caliber of the ductus venosus. This is the Bernoulli's theorem that we and then the hepatic vein joins, it also opens into the inferior vena cava, which then open into the right atrium. So this is a short vessel connecting the umbilical vein to the IVC. It helps in preferential shunting of the oxygenated blood to the fetal brain, and 20% of oxygenated blood from the, this is 80%, almost 60% of the oxygenated blood bypasses the liver. It is 20% which goes to the hepatic circulation. Now, the percentage that is shunted declines with gestation, and the portal venous blood is mostly draining the right side of the right lobe of the lip. There is where the IVC at the junction of the inferior vena cava and the right atrium, there is a tissue flap which is called the eustachian valve, which is directing the oxygenated blood along the inferior aspect of the IVC to this, which it directs the jet such that it directly crosses, the majority of the oxygenated blood is directly crossing into the left atrium via the foramen. So the IVC is shunting the oxygenated, the ductus venosus is shunting the oxygenated blood from the umbilical vein to the IVC. At the top of the IVC, where it is entering into the right atrium, there is a valve which is directing this highly oxygenated blood directly into the left, from the right to the left atrium. From the left atrium, this will go into the ascending aorta. And here, it is from here, you know that the carotid, the first arteries that come out from the ascending aorta are the arteries which are supplying the heart and the brain. So the carotid and coronary circulation thus get a preferential supply of the highly oxygenated blood. This is just an enlargement of the same diagram. So the foramen vein, the oxygenated blood going into the left atrium, from the left atrium into the ascending aorta, and then on to the carotid and the coronary. So by the time the blood reaches the left atrium, to begin with, it was 80%. When it left the placenta, the oxygen saturation has come down to 65% because of the intermixing with the venous blood. From the left atrium, it goes into the left ventricle, the ascending aorta, and then onto the coronary and the brain. Now, in the meantime, the right atrium is also getting blood from the superior vena cava and the coronary sinus, which is bringing deoxygenated blood into the right atrium. And in addition, there is some deoxygenated blood which was coming from the inferior vena cava and from the hepatic circulation. So all this, which from here, from the right ventricle, from the right atrium, the oxygenated blood got shunted into the left atrium. The deoxygenated blood is going in from the right atrium to the right. These are not watertight compartments. So there will be some amount of intermixing, and that is responsible for the oxygen saturation to come down. But because of these tiny blood vessels with increased velocity and the flaps and the tissue walls, there is a preferential streaming of oxygenated blood to the more vital organs of the body. So from the right atrium to the right ventricle to the pulmonary trunk, and from the pulmonary trunk, because the pulmonary vascular resistance is very high, only 12% of this deoxygenated blood will go into the pulmonary circulation. Majority, 88% of the blood will be entering into the descending aorta via the ductus arteriosus, which is the third shunt. So from the ductus arteriosus into the descending aorta, and from then onwards to the rest of the fetal body. So the lower half of the fetal body receives relatively deoxygenated blood as from the descending aorta. Now, how is oxygen delivery actually achieved to the fetus? There are three factors which combine to give a preferential higher oxygen saturation to the fetus. The fetus literally cleaves away oxygen from the mother, maternal circulation. For the same amount of hemoglobin for fetal blood as compared to the uterine artery, the oxygen saturation of the fetal blood will be much higher because of the high concentration of hemoglobin F, which we all, this chart we remember from our first professional exam of physiology, that because of the load to 3 dpg, the oxygen curves is shifted and the oxygen is unloaded to the fetal blood. In addition, in adults, both the ventricles, the cardiac output is measured as the amount of blood which is ejecting from either side of the ventricle over 1 minute. So, however, because the fetus, the ventricles are working sequentially, the cardiac output is much higher as compared to the adult. So, they have the fetuses have a high combined ventricular output. They have a higher hemoglobin, which is 16% heptone. They have a higher oxygen saturation because of hemoglobin F. So all these three factors ensure that oxygen delivery is maintained to the fetus despite the low partial pressure of oxygen. So this is just a summary. Please feel free to interrupt if I'm not clear or I'm rushing too fast. So just to summarize what I've spoken so far, oxygenated blood 80% from the placenta via the umbilical vein, the ductus venosus, the umbilical vein bypasses the liver. From here it is shunted by the Eustachian valve directly towards the foramen ovale. So from the right atrium to the foramen ovale to left atrium, from the left atrium to the left ventricle, ascending aorta, and to the coronary and the cerebral circulation. In the meantime, the superior vena cava, inferior vena cava, deoxygenated blood, right atrium, right ventricle, pulmonary artery, ductus arteriosus, descending aorta, and to the lungs. So, these are the three shunts. The changes in fetal hemodynamics reflect, first is, so whenever a fetus is undergoing stress, whether it is because of fetal growth restriction, whether it is because of other conditions that we will talk about today, it is these watershed areas which will show subtle changes and which we aim to pick up on our Doppler studies on the ultrasound. So this just a schematic diagram of the umbilical artery, the ductus venosus, and the middle circulatory, which is a high velocity. Each one of these will be covered later in individual talks. And the postnatal changes as the lungs become functional. There is increased resistance, the pressure in the pulmonary circulation falls, combined with the increased oxygen saturation as well as the mechanical effects. The first one to close is the ductus venosus, followed by the pulmonary artery. The first one to close is the ligamentum arteriosum, followed by ductus venosus and the fossa ovalis. The functional closure occurs almost immediately, and the anatomic closure will occur over the next few days, and the adult circulation, as we know, is established. Thank you. Any questions you have?
Okay. So it's all very clear, right? What were you telling me about the postnatal? What's the sequence?
The first one to close is the truncus arterius, because the myocardial fibers, they contract suddenly in response to the oxygen supply that is coming in from the lungs. And then the ductus venosus, but both occur within almost function closure and the foramen. The function closure is almost immediate. It is the ductus arteriosus which may close later in premature pregnancy. So the myometrum is musculature is not that responsive.
So that aspirin, when we keep saying that it should be stopped, the non-steroidals, that is for that reason, isn't it?
Aspirin is mainly
the non-steroidals.
Non-steroidal.
Yeah.
Because they will cause.
If we go back to that. One of the things we're always saying is make sure, because a lot of medications are being used, so make sure that you stop it at 34 weeks, the non-steroidal. And again, if you look at the postnatal graph, the image, it is because of premature closure of the PDA, which should happen much later, leading to potentially pulmonary hypertension happening once the baby is born. The neonatologists really struggle with pulmonary hypertension because that's something that they've not really overcome. So the babies will be doing well, and you lose them is because they develop that. And that is, I don't know how easy or how difficult it is to look for this. Dr. Ladmans, you do a lot of...
I'd just like to share one instance. There's a lady who comes to us for a fetal echo at about 34, 35 weeks. And this lady has been, we find severe ductal restriction. And what happens is that, so you have, at the ductus arteriosus, when you put your pulse, first of all, you see a lot of color lasing and the velocities. I'm talking about prenatal, ma'am. Prenatal. So fetal echo. So basically there's a high ductus arteriosus flow, and you generally need to take a history. I don't know why, I'm not a gynecologist, but as gynecologists you should tell what to use, what creams to use and what not to use, because we have to take a history. We took a history, and that lady was using Volini because of pain in the knee. And that had produced such a lot of problem in the fetus. And secondly, I want to exercise one thing, since Dr. Prashant is there. Sir, there is no consensus or nothing mentioned on these NSAID that they are not to be used on for pregnant mothers. You know, these pharmaceutical companies should understand that these drugs are not to be used with caution. If they write for children, they write sometimes they should not be used with caution. Sometimes they write that these gels should not be used for oral. This should be. No, sir. Pharma. No, sir, but it is. Agreed. I'm not the right person. I'm a radiologist, right?
Yeah, that's what I'm saying. For us, it's obstetrician or a consultant who is prescribing some medicine.
Certainly, sir.
They should have a complete detailed knowledge what they are prescribing and what could be a possible side effects.
Exactly.
Rather than we blaming a pharma company that they are preparing such preparations.
No, sir. But at least they can put a line. Caution.
They always write it. This is a category X drug, category C drug, category B drug.
The common man does not understand.
Forget about it is their problem. If a common man goes over the counter and gets some medicine, it is his headache or her headache. It is not the consultant who is to be blamed. If I am prescribing some medication, it is my problem. Certainly. That why am I prescribing?
That is true, sir.
So any OTC brand, any OTC product, patient goes and purchase that. It is her headache, and she should probably consult the consultant that should I use it. It's something like that. It has to go like that.
Right, sir. Thank you.
Non-steroidal anti-inflammatories
Yes.
are contraindicated, especially in the second half of the pregnancy. So we tell them that only paracetamol is safe for patient or mechanical counter-irritants like hot medication. NSAIDs should not be. Let's move on to the more interesting topics of the day. Nuchal translucency and Dopplers in the first trimester. Now, it's difficult to begin any talk, even though if it's confined to Dopplers without nuchal translucency. And we all must aim to give at least a picture like this to all patients who come to us for a nuchal scan. It is mandatory. Obstetricians who are getting scans must look at the reports, not only at the reports but at the images which their radiologist or their fetal medicine person is providing. One such image must be there documented in the records of the patient. So, to get a correct nuchal translucency, one must get a correct crown rump length. The image should be magnified such that the fetus is occupying almost 60 to 98% of the screen. It should be a mid-sagittal position. The gain should be brought down. Dr. Ladbans has covered most of these points in a talk beautifully, and we will again go through it as we do the live demonstration on the machine. The crown and rump points should be clearly defined. The rectangular shape of the palate should be visualized. The zygoma should not be seen between the nasal bone and the palate. The translucent diencephalon is seen, ensuring that this is indeed a mid-sagittal plane. So the nasal tip, we must see 3 lines at where the fetal nose is: the nasal tip, the overlying skin, and the nasal bone below the overlying skin, which is thicker and more echogenic. When we say that the fetus should be in the neutral position, what is meant is there should be some fluid between the chin and the chest. It should not be touching the chest. So, one can see the diencephalon, the structure which is behind is the midbrain. I can see the echogenic tip of the nose, the nasal bone. Behind the midbrain, this is the brainstem, and this is continuing as the future cisterna magna. This area of translucency, let's first come. The lowermost part is the nuchal translucency, and the part in between is the intracranial translucency. So, if I have one good CRL image, I will get all my important points that need to be covered in the nuchal scan apart from the Dopplers. So we wanted to begin this talk with just a recap. I'm sure many of you are doing scans. So this an image like this must be documented when you give out a report. So just a recap. So the CRL should be between 45 to 84 mm. The fetus should be in neutral position, meaning there should be some fluid between the chin and the chest. The magnification should be such that the fetal head and the upper half of the thorax almost fill up the entire screen. It should be a mid-sagittal section, the nasal bone, diencephalon, and the brainstem should be seen. If you bring the gain down, the nasal bone is more prominent, and one must make sure that the fetus jumps at least once, so that I'm sure that this is indeed the nuchal translucency and not the amnion that I'm measuring. The maximum distance anywhere between the occiput to the heart should be measured. So we take 3 measurements at least. However, the maximum measurement should be used. Now, emerging role of the first trimester imaging. The pyramid of antenatal care has become inverted now. When we were aiming to pick up problems like preeclampsia, structural abnormalities in the second trimester, now the focus is to pick up all these problems in the 12 weeks itself. So the 12-week clinic, which we actively promote, must be the time when we screen both for fetal as well as maternal problems and distinctly classify women into high risk and low risk women, and not so that these can be diverted to specialist care. And this is a more optimum utilization of our resources anyway. This was first based, as everything in fetal medicine, first came from Professor Nicolaides. So the high risk shift prenatal care from routine to disease specific approach, and we will reduce number of visits. Now, coming to the Dopplers, we all know the Doppler principle, which came back in as early in the 1800s and was given by Wolfgang Doppler. First, the ductus venosus. We've already covered that it is a short vessel connecting umbilical to IVC, helps in preferential shunting of oxygenated blood. This slide we've already taken. Now, coming to the assessment of the ductus venosus, it again should be a mid-sagittal position. The image should be enlarged. This magnification is not appropriate. The image must be enlarged so that the fetal abdomen fills up the entire screen. The CRL is 845 to 84 millimeter. The fetus should be quiet. We wait for a period of quiescence, the magnification, and the mid-sagittal view. So this is the correct magnification. One must put on color Doppler to show the umbilical vein, ductus venosus, and the fetal heart. The gate should be small, 1 or less. And once we put on color, because of the small caliber of the ductus venosus, one would see aliasing or yellow color because there is a lot of turbulence in the ductus venosus. So one places samples a small blood volume with a gate of 1 or less, and you place it in the area of aliasing. The angulation should be less than 30 degrees. The filter should be set at a low frequency, and there should be a high sweep speed so that you get wide waveforms which allow correct assessment of the waveform. So the typical ductus venosus waveform consists of three portions. The tallest is the ventricle systole. It corresponds to the ventricle systole of the cardiac cycle. Then comes the peak, which corresponds to the diastole. This is and the A wave corresponds to the atrial contraction or the atrial systole. So if there is increased right atrial pressure, this diastolic flow will either be absent or will be reversed. So most of us, to begin with, you are expected to do a qualitative assessment that if the A wave is present or absent, it is considered normal, and if it is reversal, it is considered abnormal. Recently, the risk calculation in the first trimester has changed to the pulsatility index of the ductus venosus. However, one does make a note of whether it is absent or reversed, or there is positive forward flow during the dead sleep. Now, so this is just a summary slide taken from Fetal Medicine Foundation. One can have contamination from the surrounding vessels if I'm sampling a bigger volume. So I may have contamination from the umbilical vein, where an absent A wave might be obscured because of the flow from the umbilical vein, or I may get contamination from the hepatic vein, which may erroneously give the impression of a negative A wave. So that is why if my pulse Doppler sample is large, and that's why Dr. Ladmans and Dr. Prashant Acharya was saying that the gate should be 1 or less, or if I'm not on the ductus venosus. What is if you see an abnormal ductus venosus at the 11 to 13 weeks, what does it mean? It may be seen in about 4% of fetuses. You will come across it out of every 100 scans you do. You will have 4 which will have an absent or reversed A wave. It is more common if I'm seeing the fetus earlier. It is more common at 11 weeks rather than at 13 weeks. It is more common when the NT is increased and in women who have low papae and in black women. So these are just associations that have been found. Present abnormal ductus venosus is associated with an increased risk of chromosomal abnormalities, cardiac defects, and fetal death. However, once we have ruled out these problems, in 80% of cases, the pregnancy outcome is normal. So if we see an abnormal finding, it does not mean that there is something wrong with the baby. It just means that that fetus needs a little more evaluation. And once we've ruled out these problems, and the outcome is going to be normal. So it is in the reversed A wave in the first trimester is found in 3% of the euploid fetuses. However, it will be present in 65% of fetuses with T21, 55% with 18 and 13. And as we said that it is associated, it is a marker for cardiac defects. So one must attempt to look at the fetal heart in the first trimester itself, including a transvaginal scan which gives better imaging. So if you look at the graph here, the overall risk of having a congenital heart defect in a euploid fetus is about 4 in 1,000. If the A wave is normal in the ductus venosus, that risk is brought down. However, if the A wave is reversed, the risk just climbs up. So we must look at the fetal heart very carefully if I see a reversal of A wave in the first trimester. It is also associated with a small risk of miscarriage and fetal death. Hence, we must do the mean uterine artery PI both in the first trimester, which Dr. Ladmans is going to cover, and in the second trimester, and one must monitor the growth of this fetus if I have a reversal of A wave in the first trimester. What is the advantage of adding ductus venosus in our routine first trimester screening? The existing combined first trimester screening, as we understand, combining the maternal age, fetal nuchal translucency, the fetal heart rate, and the dual marker, serum beta HCG and pregnancy-associated plasma protein A, the detection rate for trisomy 21 is 90%, at a false positive rate 3%. Addition of the ductus venosus assessment, it improves the performance of the first trimester to the tune of 95%, and it brings down the false positive rate of 2.5%. So individual centers have different policies. They may choose to do the Dopplers in the high-risk group, but we believe in giving the detection rate of 95%, and because it is easily doable, you can easily incorporate into your assessment of the fetus in the first trimester screening. Coming to tricuspid regurgitation, again, the tricuspid, the specifications are that the CRL should be between 45 to 84 millimeter, the fetus should be quiet, the magnification should be such that the fetal thorax occupies the whole screen, the apical 4-chamber view of the fetal heart should be insonated, the color flow mapping should not be used in the first trimester because it is not as reliable a marker as in subsequent trimesters of pregnancy. One samples a large volume of blood flow. So a 2 to 3 gate, the gate should be put at 2 to 3 millimeter, and it is positioned across the tricuspid valve such that 2/3 is in the ventricle and 1/3 is in the right atrium. The insonation angle should be less than 30 degrees. There should be a high sweep speed so as to allow correct interpretation of the waveform. And the sample volume is placed across the valve at least 3 times to insonate all 3 cusps. So one moves from the interventricular septum and goes laterally or vice versa. So a normal tricuspid waveform will have the E wave, the A wave, and the ventricle systole. In tricuspid regurgitation, one would have this backward flow of jet which is going beyond 60 centimeter per second. And it will last for more than 50% of the ventricle systole, and it will present in more than 50% of the 4 to 6 waveforms that one gets in one view. So, just a reiteration. So, the backflow is more than 60 centimeter per second, and it covers more than 50% of the systole. Now, one can have error Sometimes one comes across these stout backward flows which are lasting across the entire systole. These are contamination from the adjacent if I'm getting my aortic blood flow or pulmonary flow in my gait. So, however, the backflow will never be more than 50 centimeters per second. Sometimes because one may see this short reverse spike. This is because of snapping shut of the wall rather than tricuspid regurgitation, which will be more broader, and hence the emphasis that it should occupy more than 50% of the system. So these are the common errors one can get while looking for tricuspid regurgitation. Again, tricuspid regurgitation is seen more commonly if I am seeing a younger fetus, more at 11 weeks than 13 weeks, or if the nuchal translucency is high. It is associated with an increased risk of chromosomal abnormalities and structural defects, especially cardiac defects. If there is tricuspid regurgitation, one must examine the fetal heart for major defects. So, it is seen in 1% of euploid fetuses. So, every 100 scans, first trimester scans that you do, you will have one which may have tricuspid regurgitation. However, the preponderance is more in fetuses with aneuploidy, especially trisomy 21, to the tune of 55%. Now, it is, as mentioned earlier, it is associated with an increased risk of congenital heart defects. So, if the overall risk in a euploid fetus for congenital heart defect is 4 per 1,000, presence of tricuspid regurgitation increases it significantly. So, as part of assessment of the fetus, one must look at the fetal heart in the first trimester itself, call them back for an early anomaly scan. By that time, the tricuspid has usually resolved. If it is still persistent, one must do a fetal echo. So, just to summarize, that the Doppler markers at 11 to 13 weeks scan, the reversal of A wave will be seen in 4% of normal fetuses, but the preponderance is much higher in aneuploidies. So one must look at the combined risk. Tricuspid regurgitation will be seen in 1% of normal fetuses, but the preponderance is higher in aneuploidies again. So if I come across any of these markers in the first trimester, I must look at my combined risk, assess that fetus for chromosomal abnormalities, decide whether it needs an invasive test or not, depending on the combined risk, and follow this, look at the fetal heart very carefully, and follow this baby in the second trimester, especially for structural cardiac defects. So, assessment of DV in TR in the first trimester improves the detection rate of the first trimester training and lowers the false positive rate. The appropriate methodology is very important, which we will be covering in the later demonstration, and these are important clues to congenital heart defects. Thank you for your attention.
So again, how many of you do I saw a couple of hands raised when Prashant was asking about the DV. Do you also do the TR? Who are the people? I think it was on this side who do the ductus venosus. So do you do both? So why have you chosen that rather than the Okay, because it's a sagittal plane, it's a lot easier. I mean, it's a more sensitive marker than the TR, but yeah. What's your experience?
The experience is what we are doing. We do nasal bone, ductus venosus, and nuchal translucency, all three, and then assess the risk. If she falls into the high risk category, that is 1:100, we straight away go for invasive testing rather than going for biochemistry. If she is low risk, we do, that is 1:1000 or more, less, we don't do anything. We don't go for a combined screening to all the patients. We apply a contingent policy for intermediate group. Those females, those who are giving a risk after nuchal and tricuspid regurgitation or ductus venosus and with nasal bone, those falling in intermediate group, that is from 1:100 to 1:1000, there we apply biochemistry and we try to segregate between high risk and a low risk group. So that is known as contingent policy, and which provides up to 96% of detection rate, which is highest ever possible. So if you apply a contingent policy, you detect more with 3% false positive rate, which is equivalent. So rather than applying a serum biochemistry to all, which is really difficult in our part of the world because of the so many issues about this biochemistry, standardization of lab, which method they are using to assess these biochemical markers. And there are plenty of issues about biochemistry. Probably we will discuss this on Sunday morning. But at present, it is said that contingent policy, if you apply, that detects 96% with 3% false positive rate, which is equivalent to if you apply a contingent policy even for cell-free fetal DNA. That also detects 96% with 1% false positive rate.
Prashant can do what he's doing is because he's FMF certified and he has that risk calculator right next to him. So the rest who are not FMF certified, it would be, I'd like to know what you do. If you don't have a software which gives you a risk while you're scanning, what do you do? How do you decide that this patient is better for a biochemistry or this patient's better for an invasive? How many of you, like, do you have a risk calculation? So how do you use? Okay. Right.
If I find all three to be well within normal limits, then it's up to the gynecologist to see. I think.
See, I tell you, here there is no, I should not be segregated. This is a gynecologist role, this is a radiologist role. It is basically whosoever is doing a scanning, whether he is a gynecologist or he is a radiologist, he or she is supposed to give a precise risk assessment. That is one figure. What exactly risk this child is having of trisomy 21. That should be the motto, that should be the aim. If you are applying this, in that case, you have to do one little extra effort by putting these 3 images to FMF. And you will get a free software, my dear. So best thing is, simple, upload your 3 images and you get a risk calculator software which is absolutely free. You got it? So if at all you are making some mistake, they will also rectify. That these are the mistakes you are making, please rectify this mistake and send across 3 more images. So if at all you are following this method, why not to get this risk calculator? Am I right? We don't have to spend one single rupee for this.
It's like Delhi, what everybody is doing, though we give a risk calculator, what happens is the moment we give the NT scan value, we give all the 5 parameters, the FM angle, the nasal bone, the ductus cirrhosis, the TR, invariably almost everybody gets a biochemistry done. And over there they feed in and they give a risk factor. So irrespective of what risk factor we give, that is always followed.
Exactly, actually.
See, I tell you, there is an issue here also. Unfortunately, in which lab they are asking for a biochemical markers are to be done. Those, if at all, that lab is FMF accredited, they will ask your accreditation number. If you do not give that, they will never calculate, and they will calculate only biochemical markers risk. And that is only 65% reliable. So you have to read that report first, whether it is only biochemical markers they have done, or they have incorporated your ultrasound findings also. Have they asked for all demographic data? There are plenty of things which are, these are the issues of biochemical markers in India.
So leave that aside. What Prashant is saying is that for our population, for it to be as cost effective as possible, is that they are definitely going to have a nuchal scan. They'll definitely have a first trimester scan. So why not finish off there without actually doing biochemistry? Then she adds.
Irrespective of what we write in the report, she'll get a biochemistry done.
So no, but
that's the problem.
Your patients are the ones who can afford biochemistry. What Prashant is saying, but the general Indian.
That is fine. That's the way it should be done. But I'm telling you what happens in a place like Delhi. That is
Delhi,
the thing.
We do combine.
And there are like 5 or 6 labs who are giving a risk factor. Out of them, there are only 2 or 3 labs which go in for FM certified NT scan.
Exactly.
Otherwise, the rest of them, they give a value without the NT and they give a value with the NT also.
So
risk
this
factor.
is only 65%. It has got detection rate of 65%. Then
No,
what is the use of getting this biochemistry
they
done?
use our NT values and give a report also.
that is the reason why I always
lab,
say.
in the sense the platforms are certified. So Perkin-Elmer's, Roche and Crypto. So if any of the labs which use any of these platforms, you can accept the...
90% of the lab will give you calculated soft risk.
Individually,
Yeah.
more
It's-
as a radiologist in private
Right.
practice, when you
Are
have...
you Delhi based?
Yeah, ma'am, I'm Delhi based.
Okay, right.
So, but
Anyway,
The problem is if I have to tell my gynecologist do this, and if I do not get a patient next time, I'll prefer she sends me the patient.
That's the reality. That's okay. So let's, yeah.
So,
Fair enough. Okay,
one-
that corner, where are all of you?
one more rule which we have probably
For four.
found out about as far as nuchal, only nuchal is concerned. I have got it. It's rule of 40, 30, 20. So whatever CRL it is, if you divide that CRL by 40, you will get a actual mean mean NT. Okay, let's take example. If the CRL is 60, if you divide it by 40, it's a rough calculation. I'm giving you a very rough idea about it, what nuchal screening is all about. Let us take example, CRL is 60, right? You divide that by 40, it comes 1.5. Am I right?
I don't know.
So 60 divided by 40 is 1.5. That is mean CRL for that CRL. Mean NT for that CRL. Okay, if you divide that by 30, whatever NT comes, whatever figure comes, that is 60 divided by 30, it comes to 2. At that NT, whatever risk a priori it is there, that risk assessment will come to that figure. And if you divide that CRL by 20, probably you require invasive testing. So if 60 divided by 20, it comes to 3. 60 CRL, 3 millimeter nuchal, the risk is so high that you will have to put a needle in. That is how. No, in fact, that is what I am saying. It is if the CRL is 80 millimeter, in that case, it comes to 4 millimeter. Yeah. So even if CRL, if the CRL is 50 and it becomes 2.5, still requires invasive testing. It's a rough rule,
so this
rough
is
guide.
rough, but I mean, what we
40, 30,
encourage
20.
everyone, just to just close up on what Prashant is saying, we encourage everyone to use the 95th centile NTs. I mean, it's a chart, so.
A risk a priori.
one small question actually. Sorry, I'm interrupting.
It's okay. No.
Sometimes the fetus comes with gestational age of around 11 weeks, 6 days. There are discrepancies in LMPs. There are discrepancies in dating in the first trimester sometimes. Now I've seen cases the gestational age is around 11 weeks, 4 days, and the CRL comes to be around 89, 85, 86. Now what are we supposed to do in those cases?
You should date that pregnancy by the CRL of your first trimester scan if the difference between the gestational age by LMP and CRL is more than 5 days. This is the correct time to date the pregnancy.
Okay. Even if the
above
patient
84, you don't do first trimester screening. I mean, you are asking about if it is more than 84 mm, you can look at the markers, but you will not be able to calculate the risk.
the risk.
In fact, most of the Down syndrome which I missed were because they were done at the wrong CRL.
Yeah.
So they should not be given risks.
I wanted to know that we are calculating the combined risk on the basis of many parameters. So if you have sometimes, one parameter which is deranged, but the combined risk is not really high. Say, for example, you have an absent nasal bone, but everything else really is normal. Or if you have an A-wave reversal in ductus venosus, but nothing else is wrong, then how do you calculate the risk? Does it change? Or is it still the combined risk? So it's the combined risk that we take.
I have to put in CRL, I have to put in NT, I have to put in, if I have seen a nasal bone, if I have seen ductus, and I'll calculate the risk first. If the risk is more than 1:100, I'll put a needle in. Risk is more than 1:1000, I don't do anything, even if there is an absent nasal bone. It could be absent in 10% of Indian population. Ductus reversal does not mean this is aneuploidy. It could be a cardiac. It could be normal in 6% of the patient. So best thing is calculate the risk, whatever figure comes, that on that figure you have to counsel, and on that particular figure you have to follow her up. And to get this figure you need software, and for software you need to upload 3 images. It's simple.
You know the three software people are here, Astraya. So maybe in between for a few minutes, I'll ask Claudia to come in and sort of show you. I can't emphasize enough. I mean, it is stupidity on our part that when the Fetal Medicine Foundation is giving a risk software, then Prashant can sit there and do it. That when they're giving it to you, all they require is just submit 3 NT images. I mean, it's so simple. It just doesn't make sense that why people are not taking it up. But yeah, so that I mean, they'll Chanchal and Dr. Latbans will demonstrate the technique.
Placentation effects are preeclampsia and FGR. We understand IUGR is the third leading cause of maternal perinatal mortality after anomalies and prematurity, but it does not remain only to the womb. Look at the impact onto the society. Children who are born with IUGR are highly prone to having hypertension and coronary artery disease, in addition to neonatal mortality and psychoneurological delay. Preeclampsia, all gynecologists know what it is. I'm not going to go in details, but I just like to highlight that the incidence is much more in developing countries and the data which are established in the West. Now, preeclampsia, look at the risks in the later decades of life. It is also prone, the ladies are more prone to hypertension, ischemic heart disease and stroke. The reason they have given is because of the high central aortic systolic blood pressure and arterial stiffness which is there in these group of mothers who have preeclampsia. So the key vessel for prediction of preeclampsia and FGR, which my role is to tell you about uterine artery. Coming to the normal placentation, let me take you through the placentation of the uterine artery. It enters the uterus and gives off arcuate arteries which run circumferentially all around the uterus. Radial arteries extend from the arcuate and enter the endometrium. From there, the spiral arteries arise and connect the maternal circulation to the endometrium. Broad overview of normal placentation. What happens exactly in the spiral arteries? Now, under normal conditions, there is invasion of the cytotrophoblast, not only in the decidual part of the spiral arteries, as shown, but also into the myometrium. So what happens is that there is a large channel which is produced and increases the flow to the areas which is being supplied. So you have a small muscular artery which is invaded by cytotrophoblast and produces a large vascular channel of low resistance. Vis-a-vis in abnormal circulation, the small muscular artery, there is loss of cytotrophoblast, so the muscle which is there in the myometrium also enters into the decidua and constricts the vessel and produces less flow into the placenta. Other causes are there which I'm not going to go in details. There are indications for uterine artery where you have a previous history of preeclampsia or IUGR, unexplained high maternal serum markers like AFP and beta-HCG, and low papillae levels. Now, steps to record uterine artery Doppler are a correct interpretation is required because it needs a standardized methodology to do it. Step 1 is you need a mid-sagittal section of the uterus here. That's the mid-sagittal section. I will be demonstrating it to you as well, which is obtained by looking at the lower segment as well as the cervical area. You need to zoom that particular area of the lower segment and the cervix and a partially full bladder. I feel it is important because when you put on your color boxes, it displays a better image. So once your color Doppler box is on, you take it laterally, trace the paracervical area, you have the vessels, and there you have the ascending branch of the uterine artery, which is identified, which you need to map up. Because if you map up the arcuate arteries, they will give you false flow and they will not be of optimum level. For doing spectral waveform, you need a gate of 2 mm, an angle of insulation should be less than 30, peak systolic velocity in that particular vessel of the uterine artery should be more than 60 centimeters per second, obtain 3 consecutive similar waveforms, and then you need to average the right and the left, and then you give the results. So you have another method of doing a transvaginal technique. The lady is made to pass urine placed in lithotomy position, and the similar method to trace the internal loss, you need to go laterally and then place your color Doppler and take up the ascending artery. The pitfall is you do not enter into a cervicovaginal artery which descends down. So you have to take a vessel which ascends up in the lateral fornix, or even otherwise if you're doing your transabdominal technique. So where to map? Whether to map at the cervix or map at the iliac crossover. Ideally, you should map at the cervix, because they've established that there are differences in the PI, right? So you may getting a falsely low PI at the iliac crossover. Second, sometimes because of the small sized uterus, you may not be able to see the iliac crossover, or the iliac crossover could be far away from the cervicals. So these are the mapping of the uterine artery shown at the cervix and at the iliac crossover. You see the difference in the PI. So coming to the abnormal uterine artery waveform, what happens when there is narrowing or thickness in the spiral artery? Whenever the muscle thickens, the blood which is coming from the uterine artery is reverted back. There is a sudden springing up of the vessel of the uterine artery that produces a late deceleration of the flow, and when the uterine artery recoils back, it produces a diastolic flow with a notch. So this is the mechanism how the abnormal uterine artery is produced. A normal uterine artery will show a gentle dilatation, a steady flow, and a gentle waveform. Now, in abnormal uterine artery, the statistics are that you have the presence of a notch or looking like a notch seen in the first trimester, which is commonly observed in normal population. So you need an index where you have to have a cutoff level. So what we take it as a pulsatility index, when it is more than 95 centile, that is the time when we say that it is more. We need to take both the sides, average it, and see whether you are falling for the beyond the 95th centile. That is the time when we say the PI is elevated. So this is variable for various gestations. Now we understand that the uterine artery is very useful for risk prediction. It has a negative predictive value of more than 99% and a positive predictive value of 50 to 70%. And this has been backed by a large meta-analysis, which also show a large specificity and a low sensitivity. So if we are doing Down syndrome screening, we see the prevalence of Down syndrome is 1 in 600. So if we see very severe eclampsia, we see that it's twice the number of Down screening. So it should be included. We do rampantly for Down screening. We must think about preeclampsia. We should include it into a first trimester package by not only doing a uterine artery PI, but also looking at the blood pressure of the mother, adding up the 2 placental growth factors, and predicting preeclampsia before 34 weeks. So to conclude, it's a wonderful tool. Uterine artery is a wonderful tool to predict IUGR preeclampsia. It is a high negative predictive value. Uterine artery PI should be more than 95th centile of period of gestation to say that it's abnormal, and preeclampsia screening should be offered in the first trimester along with the downstream. Remember, it takes just 2 minutes to map up your uterine artery. So that's the message to you across. In addition to your ultrasound which you're doing, just spend another 2 minutes to complete your uterine artery. Thank you. 95th centile. So it is something like 2.7. Turns out to be 2.5 to 2.7. It's basically we are trying to take the uterine artery of the right side, and then we take PI of the left side. We add up, divide it by 2, and then what's the value? We check it up with the reference charts which are available, and that is that if it's supposed 2.5 for 11 weeks, it is 2.5. It's more. So that's how I do it.
See, there is one thumb rule. In the first trimester, it is 2.5. In the second trimester, it is 1.75. if mean uterine artery PI is more than 1.75 in the second trimester, that is improper placentation because it is more than 95th centile.
That
And in the first trimester, it is coming to 2.5. So it is 1.75. I can show it. Do you have that chart with you, ma'am? Can you just display it? It is
1.45. At least FMF is 1.45 for abdominal and 1.6 for transvaginal.
So anything above 1.75 is crossing 95th centile. So that should be considered. It requires further investigations. Or second trimester 1.75. First is 2.5.
It's not. It's 1.45.
At 6 weeks. 6 weeks we don't do it, honestly. We start only after 11 weeks. CRL becomes 45, then we do uterines. 3, yeah, of course. Even they utilize for IVF pregnancies also.
Have you had your outcomes followed up? Why have you decided 3?
So can I add? I have the charts in front of me.
Okay,
Can I add, please?
Yeah.
At 12 weeks, it is 2.5.
It's not transmitting.
No, I'm
Okay,
speaking
okay,
it. It's
so-
in front of me. It's 12 weeks, it is 2.5.
That's what I'm saying.
At 13 weeks, it is 2.38. At 14 weeks, it is 2.2, sir.
Yeah.
And if you go to 18th week, it is 1.7. And 20 weeks is 1.6, ma'am.
So that is, it's a rough, in second trimester it has to cross 1.75 just to let our brain takes less stress. It is pone do or dhai, it's simple.
Because you can start aspirin fairly early.
Aspirin
is on the first trimester.
Even at a second trimester, even till 23 week, it will have its utility. Because this remolding will continue till in the second phase till 23 weeks. So whatever benefit, if you really want to manage a patient, those who are obstetrician here, I would probably request you to investigate that lady for thrombophilias. If at all she is having this improper placentation, you may find out something there. If something is there, say antiphospholipid syndrome, which is positive, indirectly it will show you reflect on uterine artery Dopplers. If you investigate her, if she is having thrombophilia positive, antiphospholipid syndrome positive, then you have to start not to investigate her lady. If everything comes negative, you can start aspirin. But if something comes positive, you may have to switch off either steroids or heparin, adding on to aspirin.
But it would be interesting to follow up these.
This 3 PI
I mean,
is really very helpful even in to know what is a possible implantation rate or what is possible successful pregnancy occurring into that endometrium. That's the reason we are using. It is known as Applebaum scoring. This uterine artery PI is utilized what is known as Applebaum scoring. That is utilized particularly for success of the implantation in a particular IVF cycle.
We have a gestation of about 11 to 12 weeks of pregnancy, as we just did the CRL. And we have the sagittal section, true sagittal section of the uterus. As you can see, that's the fundus, the body, and the cervix. Can everybody appreciate the cervix, please? Yeah? So we have the mid-sagittal view of the cervix. You can very well visualize the internal os and the external os, right? And at the level of the internal os, we tried, can we zoom a little? Yeah, okay, slightly less. Okay, now we have the image, and that is predominantly covering the lower uterine segment and the cervical area. So we're going to put our color box on, yes. And moment you put on your color box, you go to the lateral aspect, and that is the ascending branch of the uterine artery. Can you visualize this? Yeah. Yes, everybody can. That is on the left side. Can we have the pulse Doppler, please? Yes. That is the waveform which we are getting. Can we correct it a little? And the PI is 2.0, right? Yeah, to 2.1. Deep freeze. Okay. So that was the left uterine artery. You see the bladder is full. Sometimes if the bladder is empty, you have a little difficulty in visualizing the uterine artery. So can we go ahead and put the color, zoom and put the color box on? Yeah. Make sure you are at the level of the internal os. If you are little above or below, you may not visualize the uterine artery. Yes. Yeah. No, the principle in the second trimester is you have to take it at the, okay. This is 2.0. Switch it up.
So then about 2.
Yeah. So she has a normal uterine artery PI values.
What needs to be pointed out here, that if you just look at the appearance, you could see perhaps in one of them there was a notch. And this again re-emphasizes the fact that we look at the mean, because the mean was around 2, so she would still be classified as a screen negative. And I think this is a sort of important point to note. Can we just see the waveforms of the... Oh, you didn't save it. Oh, she didn't save it. But if you had looked at the... No. Oh, okay. Huh. If you looked at the waveforms, you would have seen that it seemed to be like a notch. But anyway, this would be screen negative. So, Dr. Latmans, why do you take PI rather than ST, etc.? Can you talk about why we use PI rather?
But I feel that's a better cutoff value, because see, normally you are seeing high resistance flow in the first trimester. You know, if we are trying to say intrasystolic notch, or everybody will come out to be positive that way. If we are looking at notches and making our diagnosis based on just notch, that means we are not doing the right thing, because you are already looking at a high resistance circulation at this particular period of pregnancy. So you need a particular cutoff. So pulsatility index is as close to taking a good value, and it has been shown in, it has been backed up by so many articles that it's the 95th centile which should be taken into consideration.
Achha, let us discuss some of the methods, how to do this uterine artery Doppler. Right, one, Dr. Latman's score has shown that go in the midline, trace the cervix, then rotate your probe on the right and the left side. One simple method, just put your probe almost vertically, exact 90 degree between anterior superior iliac spine and pubic symphysis. That midpoint, if you put your probe midpoint, that is the place where you will find uterine artery, straight. Second, if you don't find uterine artery, if it's difficult abdominally, you can always do a transvaginal scan and you can get the tracing of uterine artery. These are the three simple methods. Transvaginal is the simplest method. Anyhow, you are going to do a vaginal scan for cervical length measurement. In that case, do it. It will take not more than 1 minute to get both waveform. So adding to your cervical length, make it on every side, you will get this uterine artery Doppler simple. Or a midpoint, exact midpoint between pubic symphysis and anterior superior iliac spine, that there you will gain both the uterine artery Dopplers.
So that is right, but that is not to be advocated in the first trimester. That is what they say, because that is the time when you are going to see the islet crossover of the uterine artery.
That is there. These are the three methods I am saying.
I have already.
So just put it.
Certainly, sir, certainly. Now we have a fetus in a beautiful position, as actually we want always to be, but we are not every time fortunate enough. And can we have the color on, please? So, and zoom it.
So you're demoing the ductus?
Yeah, I'm trying to demo the ductus venosus, ma'am, for you.
Baby moving?
Never. Yeah, that's okay. That's okay, ma'am. We can't stop the baby moving. That's not possible. So anyway, we are trying to go mid-sagittally. We've tried to zoom. Can we zoom a little more, please? Yeah. Switch off your pulse and reduce your color box size. It's very important to reduce your color box size once you are into that particular area. You want to look at the high aliasing area at that in the mid part of the abdomen. Can we have the Doppler? Yes, here it is. Yeah, just place the pulse. Yeah. Freeze. Yeah, yeah. Yeah, we've got a adequate, not so adequate, but yes, we have got a pulse waveform from the ductus venosus. We can certainly try it again, but if you get such kind of thing, you know that you're not in the right place. You can redo your sample again. Yeah, yeah. So zoom needs to include your thorax and the upper part of the abdomen. That is to be taken into consideration. Zoom this area. Yes, zoom it slightly more. Yeah. Put on your color. Yeah, put on your pulse Doppler. Place it here. Yes. Yes. That is a better one. As you can observe, that this waveform is a triphasic waveform, as been already highlighted by Dr. Chanchal. You have the S wave, you have the D wave, that's the S wave. Can we have a marker? Yeah, marker. Arrow. Okay, that's the SD. So the most important waveform, we are looking for the diastolic part. The diastolic part, and that is the late diastole, where it has been mentioned as 1. So you need to see this particular area. That is the point where you need to see whether there is decrease in the atrial contraction, there is reversal. So these are the two areas which we need to focus when we are doing your ductus venosus. So not only ductus venosus is helpful in the first trimester, and also in MCDA twins it can be useful, and even in later part of the pregnancy to do your management in obstetric Dopplers as general. So that was the ductus venosus, and I think we can show a bit of TR as well. Yeah. Okay, that is the area of the thorax which we are getting. We'd like to zoom that particular area so that the entire thorax, including the heart, is seen on the screen. So partly you can see a 4-chamber, apical 4-chamber view of the fetal heart. Can we have the pulse only, please? Yeah. So you need to place it on the, with a little wide sample. Can we increase the gain? Yes, we can, sir.
It's a completely new machine we have given to Dr. Ladbans.
Okay. Anyway, it's okay. So can we place it here? The sample gauge size needs to be big, 2 to 3, so that it is not only seen across the orifice, but also includes the part of the atrium and the ventricle. We're going to redo it. Baby has moved. Okay. No, you just put the pulse. Yes. Set. You can see it below the baseline. You can see you are catching the aortic snap. So it's okay, fine, so long you are getting an E and A wave below the baseline. So the upper thing is not, above the baseline is not the wave. It's the lower E and A wave which can be seen below the baselines. The upper one is due to the aortic flow or the pulmonary flow. So these things you need to know. This is not looking, there is no tricuspid regurg in this patient. Yeah.
We'll try again, Mami, the position.
That's the thing about preset. If you have the TR one,
Set, please. Freeze. So this is much better. As you can observe, can we invert it? Yeah. Yeah, that is the E and the A. The A is wider and taller as compared to the E wave as visualized in the adults, where E is bigger than the A. And secondly, this is because of the poor compliance of the right ventricle at this particular period of gestation. And if you have TR, it should be, as we've been already said, that it should be more than the systole and more than 60 centimeters per second. And secondly, the TR today, there was a latest article in 2015 which said that TR in aneuploid feti is primarily because of the volume overload, right? And there is cardiac diastolic dysfunction which is responsible for TR in aneuploid feti. So it is not only marker for aneuploid feti, but also can help us following up patients with cardiac abnormalities. If you certainly find TR in this period of pregnancy and you have a normal, chromosomally normal fetus, it is always advised to do an early fetal echo and also do a transvaginal scan at this time to at least assure that your chamber anatomy is all right. And also you need to follow up these babies at about 16 weeks for a good detailed fetal echo. So that is my basic message to you all. That's it, ma'am.
Thank you, Dr. Ladmans.
So Chanchal, can you, have you got a collar mic?
I have.
Okay, thanks. You stay. So you think that you can talk through, because he wants the proper tip for NT. Chanchal is sort of setting up, but essentially the thing which is absolutely the easiest to do is to get an axial plane of the head and then rotate it such that when you look at the screen, that it is at 90 degrees. And then you just turn your probe 90 degrees to that, and you get the NT. She'll show you once with the both eyes looking up, correct. So that both eyes are looking up, and then just turn 90 degrees and you get the absolute sagittal. And then just with your probe, just move a little bit like this. No, but that is the only tip. You'll get it all the time. It's 100%. PI. No, PI. Because of the fact that if you have reversal, you won't be able to get a RI measurement. So if you have absent or a reversal, whereas with a PI, because the denominator is velocity, you'd always have some velocity. At least the last 10 years papers which have come out, they've all been alluding to PI. So I'm not aware of it. Dr. Varun, Dr. Kuldeep, she was asking RI indices for first trimester.
Yeah, 0.95 at 6 weeks, 0.90 at 12 weeks, that is the scan that we are doing. And thereafter you have to go for the notch and the PI. You see, though I'm talking about 20 weeks now. So at 20 weeks when you do, you have a PI of 1.45 and a notch. And if you go into the software, you'll realize that if you're going to give them 4 points. 1 for notch on either side, that's 2 points, and 1 for PI more than the cutoff, that is 1.45 on either side. So 4 points. So if the person has 4 points, 80% chance of PET in the 3rd trimester. 3 points is 50%, then 30% and 10%. So if just one artery has a PI more than 1.45, I'm not talking about mean now. One artery, and so then 10%. No notch, only one above. So 10% is a prediction. If it's also got a notch, so then it gets 2 points, then 30%. If both sides are notched and high, it's 80% chance. So that's at 20 weeks. The one we are talking about right now is RI is 0.9, and otherwise RI 9.95, the one we talked about at 6 weeks, or even the one when you do endometrial receptivity for IVF transfers. Are you doing that?
The criteria that the fetal medicine people use is slightly different. What we say is just take the mean.
So in the first trimester we use PI, but we have centiles. We convert these values into multiples of the median. So, which is why, and what Latmans and all were talking about, were multiples of the median value. And there are normograms for that, which if you go on the FMF website, you will get. So if you just put in your velocity and you put in the CRL and the age and things, you would get the MOM of that. And it's, and then if that is more than 2, then the chances that there may be preeclampsia. I mean, it's why we use it in the first trimester is to decide to start aspirin or not. And the thoughts were that because notch can be a very subjective assessment, I may think there's a notch, someone else may think there's not a notch. Do you talk about deep notches? Do you talk about bilateral notches? So to take away from that, it was thought that it's better just to have a value, just to have a figure. And in the first trimester, we take more than the 95th centile MOM for that CRL. And in the second trimester, we take the mean of the 2 uterine arteries. Again, we don't look at the notch. We measure the 2 uterines and take the mean of that. And if it is abdominally more than 1.45, we start aspirin. And if it is vaginally, you've done it, and it's more than 1.6, we start aspirin. Most of, if you look at all the papers, the sensitivity of even second trimester, which has been well validated, the first trimester not so much, but if you look at the sensitivity in the second trimester, it's only about 30% that will end up with preeclampsia. But the specificity is very high. So you are very comfortable saying that, look, your uterines are normal, and the chances, we are 99%, 97 to 99% sure you will not develop preeclampsia. Okay, so it's actually, and that's how it works actually even in the first trimester, that your specificity is very high rather than your prediction of the problem.
See, I try, okay. Natural. That is the reason why I take a mean PI. Now, how many of you are obstetrician? Can you raise your hands, please? Yeah. Now, here, the important clue for as far as uterine artery Doppler is concerned. See, where everybody is discussing positive predictive value, इसमें इतना होगा, hypertension हो जाएगा, preeclampsia हो जाएगा. I utilizes negative predictive value. The reason is simple, because it has got positive predictive value is only 50 to 65%, which is really low. But the negative predictive value is more than 93 to 94%. The meaning is, if uterine artery Doppler PI is within normal range, 93% these female is not going to develop complications of PIPIP. This PIPIP is preeclampsia, IUGR, placental abruption, intrauterine death, and preterm labor. So that PIPIP complications are not going to develop, and that is where we can segregate high risk and a low risk patients. Okay, if that lady has got normal PI value, then I'll put a blue stamp on her file that she is low risk. I'm a little bit less worried about that lady. The moment there is abnormal presentation, I will investigate her for thrombophilias. If that is negative, I'll start aspirin. If something is positive, I'll go for heparin or dexamethasone combination, and I'll put a red stamp on her file that she has got, and I need a probably closer follow-up of that lady. So using a negative predictive value of this uterine is really very vital for all obstetricians, those who are practicing.
For anyone, because our job after a scan is to tell this lady, please go away, you're going to be fine. And that's the purpose that you're scanning her for. So to be able to, with authority, say that, look, we don't think you're going to develop problems is really very reassuring for the couple.
So as we were covering, when Dr. Ladvins were looking at the baby was jumping around. This is how I want the baby to be when I want to measure the ductus venosus. In this, we wait for a phase of quiescence before we put on the Doppler. Then enlarge the fetal abdomen and the thorax, put on color. Once we put on color, decrease the size of the zoom box. The aliasing that I see, so I can see the fetal heart, the umbilical vein, and the aliasing in between. Put on. So you get. So that was the ductus waveform that we were getting. So the baby has decided to move again, put off the color. Somebody was asking about the zoom, unzoom. So to measure the correct NT, I have to get a sagittal view of the fetus. So mid-sagittal view. First trimester is mainly patience. So you just... So you can see that since the baby is moving, when I said that the baby should at least show one fetal movement, so that I'm sure that this is indeed the nuchal translucency and not confusing it with the amnion behind. So to get the correct NT-NB measurement, I must have the fetus should be, the fetal head should be magnified such that it fills up at least 75% of the screen. I am seeing the clear space of the diencephalon, the midbrain. The space which is behind the midbrain is the future fourth ventricle or the intracranial translucency, and this space behind is the fetal nuchal translucency. And the measurement should be the lower line. There should be preferably no break in this line that you see here. Sometimes when there is a nuchal cord, one side will be more prominent than the other. Then we measure it both above and below the cord and take a mean. So the measurement of the nuchal translucency has to be on to on. So the horizontal line of my, I want to measure it. No, Dr. Kuldeep, no pointer. So this is on the on-to-on measurement. This is how the nuchal translucency is measured. Now, we've covered that this would be an extended CRL. The NT should be measured in the neutral position. If the baby has got its neck flexed, then I will get an erroneously increased measurement. So we'll just check the TR once again. So I have to have an apical 4-chamber view of the heart. इसको enlarge कीजिए, zoom कीजिए. So in the apical 4-chamber view of the heart, one has to identify which one is the right ventricle. However, Dopplers are best measured if you wait for the baby to be a little quiet. It is very frustrating to just keep on running after the baby when they are not in the mood to show. So now this baby has decided to show me the back. I guess we're done for the day. Any questions? Yeah. See. Yeah, if you are not parallel to the nasal bone, I will wait for this baby to turn if I can get it. As I covered in my talk, if you are not parallel to the nasal bone, you may miss it. So, and the zygoma should not be visible. So in this image, yeah. So in this image, this is above a completely rubbish image for the nasal bone because I can't see, that is not the correct mid-sagittal plane. So I must get the images that I showed in my presentation. Let's see.
So overall, the situation is
You can give it this mic.
99% with MT and biochemistry to all patients, whether I get like MT and biochemistry intermediate group, I've got the same detection rate.
I'm not getting the NP as of now. Maybe we can do it later. So this would be an incorrect image, but because my zygoma is obscuring. So I'm moving my probe such that I'm in the perfect mid-sagittal plane, and I have to see the three. See, if I enlarge this image, just enlarge this would still be an incorrect image, and that's when what is meant when it is said that you turn your probe by 15 degrees to the horizontal, so that this zygoma should not be visible. So here I am seeing the tip of the nose and the overlying skin. That should be the nasal bone, but this is an incorrect image, but because my zygoma is coming in the way. So it has to be perfectly mid-sagittal. No, I have not even spent 15 minutes looking at this baby. So I would maybe wait for a little more time and get the patient to come back again. So here, the baby's hand is on the face, so sometimes one can shake the child. The NT is absolutely fine. The ICT is okay. So if you, just to get an idea whether the nasal bone is indeed present or not, one can look at the retronasal triangle. So when you look at the retronasal triangle, if you see these two dots which are separated from the zygoma, these are the tips of the nasal bone. Do you see these two dots? That's the tip of the nose. There are two dots just below that. Just again, thoda sa confused. Can you see? It's just a matter of spending time. Can you see? One should make an effort to look at the nasal bone and not just, though nuchal translucency is indeed the most important marker for predicting aneuploidies, one should not let it go. FMF would not accept this image at all. No. These are 2D. So, there are a few papers which say that you can take the section plane. However, most of the time, the fetus eventually comes in. You haven't had the problem. If you can't see the abdominally, one can see the diaphragm. One should spend time with the Here I'm getting the zygoma. So I'm just turning my probe by 15 degrees so that I get the zygoma out of the plane. The zygoma should not be seen in my This would be the correct for the nasal bone. But again, I would rather wait and get this baby to move its hand. So this hand is but this is the nasal bone. That's the rectangular plate of the palate, the diencephalon, midbrain, intracranial translucency, and the nuchal translucency. Okay? Shall we move on to the next talk? Thank you. Sorry?
Okay, Okay, so we cannot measure nuchal translucency separately if we are not seeing the nasal bone in the same image.
You may have to. I mean, that's a
How
compromise.
accurate will we be?
That's a compromise. I mean, that's given that that's not accepted by the
FMS.
the great foundations that we are talking about.
Fine.
I'm not part of it.
So some articles in literature mention the nasal bone length as a ratio of nasal bone with respect to the biparietal diameter to be less than 11.
Correct. But
What is the relevance of this?
No, that's not been verified. 2.5 mm in the second trimester is the cutoff.
Right.
As far as first trimester is concerned, you're supposed to be able to see it. And
Whether
that's
it
a
is-
lot.
It's a dot or whether it's a
Yeah.
linear profile, and
Yes,
it doesn't matter.
yes, in the first trimester, which is why I think it's not yet incorporated in the mathematics of nasal bone. Is not really incorporated. No, in the first trimester, it's not. Yeah, it's otherwise it is
Various
3.3.
articles are there in the literature on the net as to hypoplastic nasal bone, the absent nasal bone, the
Yeah.
short nasal bones.
I think the only thing accepted. Yeah.
Okay. Fine.
And up to 18 weeks. Yeah.
The calculation, if you got a new group, if you got a CRL of 16 or 1.5, absent nasal bone with the ability, everything's fine. In a 25-year-old, it needs to be fine.
There is one more thing I'd like to develop on this. I mean, this may be slightly out of context right now, but when you give aspirin or even low molecular weight heparin, which is the new aspirin actually, there's nothing great about heparin, remember? Okay, so he'll tell us about that.
Daily injections, 300 rupees a
Yeah,
day.
300, yeah, it's the new aspirin. That's the new aspirin, that's all.
If I say that diclofenac sodium is better paracetamol, it's something like this.
Yeah.
It has got its own advantage, it has got its own disadvantage. There are few things which aspirin has got better, there are few things which low molecular weight heparin has got better.
Correct.
Ultimately, effect is it will not allow platelets to aggregate. That's an end point. But aspirin, the effect will last for 7 to 10 days. Low molecular weight heparin, the moment I stop, within 24 hours, effect is gone. If I have to operate, if I have to deliver that lady, if that lady is on aspirin, I have to think so many things.
Right.
Right. So it is as such, effect is same, but molecule is different, has got a different capacity of working in the disease, and it is definitely a different molecule as such.
Now, when we talk of giving or not giving aspirin, whether or not it is, one of your thrombophilias are positive or not positive, regardless, the end, what we are philosophizing is actually that the path eventually taken by those thrombophilias ends up as high resistance. It ends up as high resistance.
Exactly.
So,
but that high resistance.
So regardless of whether you've tested that or not,
Are
you going to recommend aspirin if you find it high?
I will recommend aspirin if there is improper placentation. Yes.
Yes.
But I would also recommend that you investigate that lady, and if she turns out to have some of the disease of thrombophilia, say antiphospholipid syndrome positive, in that case I would definitely add on heparin to that lady.
Right.
Because the combination of aspirin and heparin in thrombophilic patient or in antiphospholipid syndrome positive patient is way much more better than only aspirin.
Taken. And tell me, when would you do it? Would you like to do it at 6 weeks or 12 weeks or 20 weeks?
I would like to do at 12 weeks on a nuchal scan. When I am doing a nuchal scan, because that placentation process is not totally completed at 12 weeks. That's the first phase. And second phase is always there in the second trimester.
But the first wave occurs at 6 weeks.
It starts at 6 weeks. It is not finished at 6 weeks.
Right. The
It
first
starts at 6 weeks, but it ends at 14 to 15 weeks.
Right.
Still, I have got time to admit aspirin and probably.
Yeah.
At
so
6
that's
weeks,
just the point.
At 6 weeks, unfortunately, there is no validation available.
Right.
Yes, it is there. I definitely accept
Now,
that it will have.
all of these IVF guys, regardless of what you say, are giving aspirin.
that is one of the policy also. See, globally, in a poor country like us, we may think about adding aspirin. We may think about adding aspirin right from the first trimester. That may prevent so many problems. But is it worth or not worth? Yet there are no reports which are authentic that okay, you can add on aspirin right from the first trimester regardless whether there is any pathology or there is no pathology. So there is no harm in giving 75% of aspirin, something like that. It is going to be maybe cost effective also because cost is zero, practically 5 paisa or 7 paisa.
IVF, losing an IVF and then repeating it, I think it's much better than everybody's given.
IVF guys will give everything. Whatever 5 different kind of progesterone, if there are 2 different kind of aspirin available, they'll give 2 different aspirin also. They'll add on, I mean, the available drug, they want to keep that fetus inside uterus till 9th month. That's it.
Because money
whatever
is involved.
possible, they'll give.
Because
so
money
it is not there.
involved.
It is not probably it is the demand from the patient, and it is their need. So they are desperate and prescribing medicine like a physician. Like MD physician, if you see a prescription, there are a long list of unnecessary medicine also. So it is, they are following the same rule, unfortunately. But it's something like that.
But if there is a gestational sac, there is no harm in giving because next time when she gets pregnant, we don't know. That's another thing.
So I think.
See, gestational sac, it is much better they give it.
See, I also want the feedback from you. Anybody who has got experience. We want basically a live discussion, even participation from you all also.
I'll tell you a couple
Not only the first row should talk.
See, we don't have such fantastic research facilities as they have in the West, and I hardly get follow-ups. But the very little few follow-ups that I do have are from doctors who are patients, and that's about all. And those patients, I have noticed that when they have had these missed abortions, and they don't know what, you tell them to take aspirin. Regardless, it works.
And it is something I tell you.
So this
one loss of pregnancy has got thousands and thousands of causes. So aspirin is hardly going to, that first 6 weeks, any thrombophilias are not going to affect the pregnancy. That's the first point. First 6 weeks, any fetal death, missed abortion is never because of the thrombophilias. That is without any doubt. There is no doubt about it. Any thrombophilias which are going to affect the pregnancy either in the late first trimester or in the second trimester. Right. So first 6 weeks missed abortions are hardly because of any maternal disease. They are practically because of some of the chromosomal issues of that particular pregnancy.
Agreed.
So nothing is going to work.
Yet the action you will need to take is 6 weeks.
I think we'll put a full stop. We will move further.
All what you need to enter is the date when you do the examination. When you open the program, by default, the current date would be entered. Then you need the name of the operator who is responsible for the examination. The system is going to calculate the gestational age from some data. We will see this later. And then you start entering your data. For instance, what is the racial origin? Are there any previous chromosomally abnormal children or feti? Then you enter the parity, and so on. There are some help by colored fields where we recommend which fields are of importance to enter to get all data which are available by your profile. Then you enter the ultrasound data. What is of importance is what is the general findings. Okay, you have a fetus with the fetal heart is beating and quite a low fetal heart rate. You measure the CIL. There are some help files available, for instance, how to measure the crown rump length, how to position, how to measure the nuclear translucency, and so on. So this is meant for junior doctors, for students, and so on, and we always provide you with references for the publications. So you need to measure the nuclear translucency. There is also, if it is the nuclear cord over the neck, then you measure there. You can enter the BPD. You can measure abdominal circumference and so on. And when you move over the here the growth bars, then you see about the centiles. When you click here in this field and you press a key, F7, then you see the growth, whether it's in between a normality range or not. So you go on measuring data. The basic certainly is the nuclear translucency and crown rump length for dating, the crown rump length. And then we offer other markers, like, for instance, the intracranial translucency, and then you can enter the data. Again, there are reference charts, lots of reference charts, so you can select which one is fitting for your population, and then you enter your data. You enter the ductus venosus. Again, there are help files, how to measure it, what is of importance, what is the performance of screening, and so on. So we try to have always the relevant publications at hand for you, so that you can enter your data. What about the nasal bone present, tricuspid, Doppler, and so on. But these are, for calculation, not necessarily. These are additional markers. The uterine artery, 1.2 and 1, and then you get the data. Then there is some part of fetal anatomy you can enter, a short way, but there is also very detailed fetal anatomy. So what we did is we looked at the fetus 1, and if you have multiples, then you would enter the next fetus, and then you enter chorionicity and the data and details of the fetus. But let's stay with fetus 1. You go to the detailed anatomy. If the head is normal, then you say normal head, and so on. Now it jumps to the brain, and you can comment the data and the performance of the baby of the brain. If you have an ultrasound system which supports DICOM, then you would be able to transfer all the measurement data you see here directly from the ultrasound system to the system here. So that's, let's assume all is fine, then you click on and you go on. If you do biochemistry, then you click on the biochemistry screen, you enter when the screening or the blood sample was taken, then automatically we calculate the gestational age at that time. You select the kit manufacturer, so we support all the manufacturers who have been registered by the Fetal Medicine Foundation and are entitled to provide you moms once you have the concentration. And then we calculate moms. If you're interested in preeclampsia, then it would be necessary you measure the arterial pressure. So there is very detailed description how to measure, and at the end you do your risk calculation. To perform the risk calculation, the necessity is that you are registered by the Fetal Medicine Foundation, and then you have received an operator code which entitles you to use all the markers for risk assessment. And it's not only for chromosomal abnormalities, but also for preeclampsia, for fetal growth, and so on. To counsel your patient accordingly, there is a graphical display where you see the background risk of the maternal age, concerning maternal age, and then this is a woman, she's 42 years old, and because of the calculation we did, the risk reduced like to a woman with 24 age. So that's a vital reduction displayed graphically, and here in numbers, it's the original risk was 1 in 47, and then the adjusted risk is about 1 in 1,000. So it's very promising for the women. So if you have any questions, please let me know, and then I could answer.
What they were asking, so you can see that as soon as you enter the information, you've got that risk. So before the patient gets up, you can sit there and say that your risk is low.
So to the question that you were asking, so say there is a absent nasal bone, how would the risks change? So in this patient, if we have an absent nasal bone,
so there is the nasal bone present. We change it to abnormal, so to absent. So it makes it very prominent. So we have to go to the risk calculation. And as this patient, as this patient, this examination was done in 2014. So this patient was supposed to deliver. So let me do just, you see how to register patient. Patient's name is Dili.
So can you see, as he's booking a new patient, that's how you're booking your own patient in. I mean, you don't necessarily need to do it. Someone who's sitting in your clinic can do it. So essentially, we're just entering it and choosing the ethnicity, because that's really very important. And the sort of basic obstetric information that Dr. Dugal and Dr. Kuldeep were saying, that, you know, you need to ask them a history. And Dr. Ladman's, all of them, I mean, Dr. Ladman's has Ashraya, anyone who's come to it, they realize that you really, it is not right to do NT scans without giving them risks. It's just not, you cannot do subjective measurements, and you cannot tell the biochemistry people to do something. If you are saying that for us, in our Indian situation, ultrasound is better than biochemistry, then we need to give risks on ultrasound. You can't let someone else do that. So well, without biochemistry if possible, because what they're telling me, and then we could add biochemistry and see how it modifies, if it's possible, Roland.
Yeah. So now we do the risk calculation based on my data. The patient, let me say the patient gave her consent, and we can calculate, tells me when my license will expire. So now I have a similar patient, better conditions. You see the risk reduced from a 27-year-old patient to such a low risk that there is no woman who can be that so young and become pregnant.
So that
now we change the conditions, and we go from nasal bone present to nasal bone absent, and do the risk calculation. So the system now requires to recalculate, and you see the risk. She had a background risk of 1 in 840, and now the risk increases accordingly. As she has so good other data, so the risk is about half.
Can you add on normal ductus venosus waveform is normal. So this is, we are playing a game. It's just like a video game. Right, you ask for multiple combination, what effect of screening will have, what kind of risk calculation it will have. So let us put it 1, 1, 1. Okay. So let us see the risk calculation, how it has changed. So it has gone to 1885. So even if you have got absent nasal bone but normal ductus and normal NT, the risk is 1885, where you are not going to do any invasive procedure. She has gone into low risk rather than intermediate risk. Okay. Now about the pre-eclampsia screening which you were discussing, you have to measure that lady's blood pressure twice. Make her in a sitting position and apply your blood pressure into both the arms. Roland, can you add on mean arterial pressure? Only mean arterial pressure. Mean arterial pressure, MAP.
Yeah.
He wants to demonstrate
the
risk of preeclampsia.
Say if the blood pressure is 120/80, let us presume 120/80 means her mean blood pressure is 100. Am I right? So MAP, if I add on MAP, then uterine artery Doppler, Roland, you'll have to add on Doppler values.
Yeah. I need.
So while he's doing that, coming back to aneuploidy screening, I hope you are convinced that really this software, which I can understand if it was so expensive, you can argue that, you know, whether do you want to buy it or not. But essentially, what you just need is 3 images of correctly done nuchals, which you upload to the FMF website, and this software, if they approve it, this is sent to you free of charge. It's not, I think it is shameful if all of us who are doing NTs, when it is so easily accessible, we don't do it. I really think that it is shameful. You know, you cannot give cost as an excuse.
Let me put it like that. Are we justified in not giving the risk if at all we are doing correct things? Are we justified? If we are not justified, then we are supposed to do it. And who is at fault? Is patient is at fault or we are at fault? We are at fault. Exactly. So, is it okay if she is your daughter or she is your sister and somebody else does it like this? Will you accept this risk calculation? You will try and search who is doing the best and who is giving me the correct figures. Am I right or wrong? Then how can you expect your patient to go away with this report, whatever you are giving right now? Make sure that you have it, because it is not costing anything. It is costing your efforts for putting 3 good images. That's it. So, I do not understand why we are not putting that little effort. Please. Of course, yes. Nuchal screening, as far as nuchal screening goes, it is universally, it is same. As far as growth is concerned, Indians have got different growth pattern, and which Roland has incorporated that as Indian parameters. That is what is where it is written Acharya et al. That is there, and their Indian growth parameters are also incorporated. Am I right, Roland?
Pardon?
Is Indian parameters are incorporated for a growth?
Yeah.
Acharya et al?
Yeah.
Yes.
So I think that's clear. What it's expanding into is to also look for preeclampsia screening and so forth, which you can enter. You know, you can enter your uterine arteries. If you do the mean arterial pressures, you can enter that and you can get risks. If you do biochemistry, you can enter it and you can get risks for everything. So I think that's sort of clear. I think that's fine, Roland. I think we've got the point. We can see it afterwards. They can see you. Whoever wants to know more, fortunately Claudia is here, so you can ask her about the software a bit more. But I'll carry on because Dr. Kuldeep very kindly gave us, I allowed for this delay. So let me call Dr. Kuldeep Singh. He's 0. The entire Astraya you can buy. I mean, we've got Astraya, which does for 2nd trimester, 3rd trimester. So that's the whole gamut. But the 1st trimester module, which is the nuchal and all the other things, that is free of charge, Varun. It doesn't justify. I mean, money is not a problem for you, as you'd think. It is just the effort. And everyone knows your scans are exemplary. You are a standard in Delhi. So if you are lazy, how can I expect people in other parts of the country to do it? So I think you know, all of you need to be kind of proactive about this. Really, it's as Prashant says, it's only fair to your patients because they come to us in good faith and they think that we've screened them effectively, and really we should be doing that. 0, I'm telling you. Oh, that you can ask Claudia afterwards. That is, that's not the thing. So now, to get back to us continuing, if you don't mind. Thank you so much, Roland. Thank you very much.
Welcome. So if there is any question afterwards, you can ask my colleague who is responsible for India, or myself, or one of my friends here. Thank you very much.
Thanks. Thanks.
Good afternoon, everybody. I'm going to be basically talking more on uterine Doppler, but I'm going to be touching a little bit of the fetal-placental circulation as well. Going to start off with the utility of color Doppler, then what exactly is the anatomy and pathophysiology, and then how is it useful. We've been talking about the uterine Doppler since the morning. Basically, that's what the fetus is going to say. I'm a fetus in the womb. I fear it may become my tomb. If only I could give a shout to make my doctor get me out. So uterine arteries are going to start that exclamation of the fetus that please get me out, there could be a problem. Get me out doesn't mean as soon as it is. It basically means, yes, one has to be extremely careful so that if we need to suspect any sort of problems. In terms of importance of color Doppler, the accuracy of Doppler velocimetry in conjunction with 2D ultrasound, color flow mapping, an indispensable component of a pregnancy sonogram. And in terms of perspective, it's not that the moment somebody asks you about a Doppler or about a uterine artery Doppler, you just start off Dopplers and that is it. You have to be excluding fetal anomalies, evaluating fetal size, quantifying glycoramniae, evaluate the biophysical parameters, assess the placenta, cord, and cervix. In terms of the established facts, it identifies the fetus at risk for damage or death in utero. It's an established tool to assess the mode and timing of delivery. It predicts reasonably well the fetus at risk for a growth disorder. In terms of, it's established in high-risk pregnancy for fetal well-being, for the risk of continued intrauterine existence, and in low-risk pregnancy, it identifies a subgroup of fetuses that would require an increased surveillance. So in terms of objectives, simple for detecting and assessing the fetus at risk for death or damage in utero. Our basic aim of looking at the uterine arteries is what? To basically save the fetus for immediate fetal health and for future fetal risk. In terms of why do we need that, in which patients do we need that, and how do we go about it? 2/3 of fetal deaths occur before the onset of labor. Many antepartum deaths occur in women at risk for uteroplacental insufficiency. In terms of looking for an ideal test, allows intervention before fetal death or damage from asphyxia, and preferable is to treat the disease process and allow the fetus to go to term. In terms of what happens in uteroplacental insufficiency, there is an inadequate delivery of nutritive or respiratory substances, inadequate exchange, and inadequate maternal delivery of nutrients or oxygen to the placenta. So finally, to the fetus also, it's less. In terms of the theoretical scheme of what happens, fetal well-being starts going down, we have fetal growth retardation, fetal hypoxia with stress, we start getting effects of intermittent hypoxia, asphyxia, and death. So we have to be careful of looking at it, nipping in the bud, so that we know who are the patients who are going to be requiring all these things. In terms of conditions which place the fetus at risk, preeclampsia, chronic hypertension, collagen vascular diseases, diabetes, fetal maternal anemia, hyperthyroidism, thrombophilia, postdated pregnancy, fetal growth restriction. And how do we really go about it? We have all these tests, but the most important that I'm going to be talking about is Doppler velocimetry. We're going to be showing it to you as well. An increase in the vascular resistance of the fetal placental unit leads to a decrease in end diastolic flow velocity or its absence in the flow velocity waveform. This I'm talking about the umbilical artery, but what makes this happen is, starting is the uterine arteries, which could cause problems. Abnormal waveforms reflecting the presence of a structural placental lesion. Abnormal Doppler results require specific management protocols and intensive fetal surveillance. We're looking at uterine arteries, we're looking at notches, we've seen so many from the morning. I'm not touching on this because it's going to be touched in the afternoon. A poor indicator of fetal compromise or adaptation to the placental abnormality, but it does identify patients at risk for increased perinatal mortality. There's a strong association between high SD ratios and IUGR. In terms of implantation is a progressive process in which the embryo has to oppose and attach itself to the maternal endometrium. Invade it, it involves the endometrial side and the embryo side. And in terms of the blood supply, we have the main uterine artery, we have the arcuate arteries, radial arteries, basal arteries, spiral arteries over there. We have the anatomy over there, where spiral arteries towards the end connect the maternal circulation to the endometrium, and it's responsible for a 10-fold increase in blood flow. In terms of the conversion of small muscular spiral arteries into large vascular channels, transforms the uteroplacental circulation into a low resistance system. These have a dilated and tortuous lumen, complete absence of muscular and elastic tissue, no continuous endothelial lining. A normal implantation would consist of uterine spiral arteries undergoing extensive remodeling as they're invaded by endovascular trophoblast. If there's an incomplete invasion in terms of decidual vessels, not myometrial vessels, that's going to lead to preeclampsia. So you're looking at a non-pregnant state, You're looking at a normal state where up to the myometrium you're looking at dilated channels, and that's where you're going to find problems over there. In terms of uteroplacental circulation, perfusion, compromised uteroplacental perfusion from vasospasm, that's more of a histology as such. I'll just show you a few waveforms. And in terms of prediction, we have various biological, biochemical, and biophysical markers. I'm here to talk about uterine artery Doppler. So if you have an impaired trophoblastic invasion of spiral arteries, it leads to a reduction in uteroplacental blood flow. 8 to 22 weeks, sensitivity, the positive predictive value, it's unreliable in low-risk pregnancies as such. So you need to be extremely careful of when of them are going to be required, which of them are going to require. We have combined inhibin, we have HCG and AFP as well. That's how the waveform is going to look like. That's going to be towards the start. Then you're going to find a little increase in diastolic flow and much more diastolic flow as the spiral arteries get invaded. In terms of 6 to 8 weeks, you find in 6.3% no notches, unilateral notches, but bilateral notches in almost 81%. 13 to 16 weeks, 50% of them are almost going to have no notches, bilateral notching in 30%. 24 to 26 weeks, 85% of them are not going to have any notches, 10% unilateral, 5% bilateral. The highest risk is when there's a persistent bilateral notching even after 24 weeks. Less risk when they're unilateral notches or they normalize by 24 weeks. Again, we have the NT scan where we're looking in for, so we have shifted a little earlier to our NT scans rather than our level 2 scans for performing these uterine arteries. In terms of normal and abnormal, if you're looking at PPH, small for gestational age, this is the percentage in abnormal uterine arteries. NICU admissions, delivery less than 34 weeks is when it really increases if you're looking at an abnormal uterine Doppler. Looking at various sites over here, the most popular site is here only, otherwise you're going to be miscalculating your uterine arteries. The ISUOG guidelines, transabdominally, Dr. Ladvans has demonstrated that in the morning. We were again going to be demonstrating that in the second trimester as well. It's basically the probe is placed longitudinally in the lower lateral quadrant of the abdomen, angled medially. You can identify the uterine artery as it appears to cross the external iliac. Sample volume is placed 1 centimeter downstream to the crossover. If the uterine artery branches before the intersection of the external iliac, the sample volume should be placed on the main artery just before the bifurcation. We're going to be demonstrating that. That's a normal one where you're looking at the systolic flow and the diastolic flow. Plenty of diastolic flow. You're supposed to be seeing that the main uterine artery on the right side and the left side. If you're looking at notching, you know that's trouble. You're looking at less diastolic flow. Take out the PI on both sides, take out a mean PI, and you know that you're looking at trouble or not. Emptying the bladder, the probe placed on the lateral fornix, repeated on the contralateral side as well for the other uterine artery, and we have these reference ranges where you're looking at mean uterine arteries over there. So we have a deep notch, we have notches, we have graded into shallow notches and deep notches, but that doesn't make a difference. Once you can move your cursor over here and take out a PI, that's a mean of all the velocities. That's normal flow where you're looking at plenty of diastolic flow, no notching, you know you're looking at normal flow there. Looking at normal uterine artery at 12 weeks, it shows a relatively high resistance, absent notching. A normal mid-trimester uterine artery, you see increase in the diastolic flow. Third trimester, again very low resistance. If you see the previous chart over here, you're looking at the PI which is going down as you're looking at increase in gestation. In high resistant with persistent notching may be normal in the first trimester, but not at 24 weeks. We are looking at cutoff points of 2.5 in PI and 0.90 in the RI. Even if there is a notch, if we're looking at these, we know there's no trouble. We can again repeat it in our level 2 scans. You're looking at very high resistance, an extremely deep notch, absent diastolic velocities almost in a woman with preeclampsia, severe IGR at 28 weeks. Again, looking at normal flow, this is abnormal flow over there. So uterine arteries, they reflect trophoblastic invasion. If you have an elevated resistive index or you have a PI which is elevated, a persistent diastolic notching, presence of systolic notching, or a major left to right variation which we were looking at earlier, but now we're looking at mean PIs, so that helps us in looking at whether we should start them on any sort of medication. In the low risk mother, it predicts prediction of a hypertensive disorder. In the high risk, it predicts perinatal morbidity and mortality. We need to be careful of with the first trimester invasion of spiral arteries, that's 4 to 12 weeks, and we have the early second trimester invasion of radial arteries up to 20 weeks plus minus 2. So you have to give it a chance up till 22 weeks. Not to start the treatment, but to really be very, very worried about as such. The treatment has to start before 16 weeks, that's when it's going to be extremely helpful. You need to be careful on the region that you're sampling. You shouldn't be invading too much into the myometrium, looking at the arcuate arteries or looking at the other arteries and saying this is the main uterine artery. Be careful on that. In terms of screening studies for the prediction of preeclampsia, various studies over there. In terms of prevalence rate, low. We're looking at a specificity which is very good, a negative predictive value which is very good. That's for the prediction of preeclampsia. We're looking at, in terms of IGR babies, we're looking at fetal growth restriction below the 10th percentile. A positive predictive value is quite high, negative predictive value low. And in terms of if you're looking at borderline IGRs, we have a much more heterogeneous where we're not going to be able to really pinpoint in our uterine arteries. Looking at 5th to the 3rd percentile, the negative predictive value is very good. If we have something normal, unlikely that this fetus is going to go into too much of an IGR as such. Again, depends on the maternal intake, maternal nutrition levels also are extremely important. Last 2-3 slides, where we are going to start off with color Doppler representation of pathophysiology. First trimester invasion of spiral arteries, second trimester invasion of radial arteries. If you have an improper trophoblastic invasion, on the ultrasound, on your Doppler, you're going to look at as abnormal uterine arteries. Just going to touch a little bit. If you have increased placental obliteration, abnormal umbilical arteries, we have a reflex redistribution where you're going to find problems in the descending aorta, more flow towards the middle cerebral artery, that's going to be touched in the afternoon. And the last points where we start finding problems in the venous waveform. In terms of protocol for color Doppler in clinical use, if we have a previous obstetric history of low birth weight, IUD, stillborn, NND, preeclampsia, we are going to be looking at in our NT scan. But because my topic is in the second trimester, we're looking at 20 to 24 weeks. If it's normal, we require a routine management and a complete Doppler study at 32 weeks. If that's normal, routine follow-up at 36 to 37. If that's abnormal, we start looking at specific umbilical artery, then middle cerebral artery, then ductus venosus. If you're looking at an abnormal uterine artery at 20 to 24 weeks, repeat after 2 weeks, normal, again 32 weeks. If it's abnormal, start monitoring for proteinuria, preeclampsia, IGR. Depending on if it's present, management and a complete Doppler study. Complete Doppler study would mean you need to be looking at your fetoplacental circulation as well. If it's absent, an expectant management and a complete Doppler study at 32 weeks. I'm not going to be touching on this portion over here because that's going to be touched in the afternoon. So friends, uterine artery is extremely important in the second trimester as well. Apart from that, yes, you've seen something which could be abnormal. The treatment has started, but you need to be looking at, has it improved in the second trimester? If it hasn't, you need to be cautioning your obstetrician, or if you are an obstetrician yourself, you need to be careful of, start thinking about it from 26, 28 weeks, that when is the right time to deliver, so that we do not want these fetuses, there should be a fetal loss inside. Thank you so much.
So, any questions? So the second trimester, because it's been really well validated, to some extent we believe it should be used as a universal screening. Do you agree with that?
Basically, because we're doing NT scans almost now on everybody, so we are doing our uterine arteries. We start the treatment, we ask for a scan repeated at 16 weeks so that we know how's the treatment progressing. Otherwise, then when they come back between 18 and 20 weeks, we definitely do that. Depending on what sort of an improvement is there, we again see whether we should be repeating the scan every 4 weeks or we can leave them till 28 weeks. That's the protocol that I follow.
A lot of patients come after the first trimester, no? So
then we don't have any choice, but in our level 2 scans we do that. But supposedly if the uterine artery is normal, I'm getting a resistive index which is less than 0.55, or we're looking at a PI which is less than 1.5, we've taken a mean of it, I'm not finding any notching, then we're comfortable that this fetus is not going to be susceptible to any sort of problem. The mother is going to be fine as well.
So I think it's very clear, all of you who are scanning, that if by chance, well, even if you've done first trimester, between the two, because there's much more experience with the second trimester uterine artery Dopplers, I personally think we should still do it, even if you had a normal first trimester, because of the fact that it's been around for a lot longer, and it's been validated much more, and we know how it performs much better. So I think it's a good thing to do. So we'll demonstrate it in a bit. Yeah, for abdominally, but you can also do it transvaginally, in which case is 1.6. Remember, if you do it too early, I mean, it's been validated for between 22 and 24 weeks, so after 2 weeks. So if by chance she comes for a scan at 18 weeks and the uterine artery Doppler is high, you must call her back, because that could just be physiological.
See, a few years ago, what used to happen was, we weren't doing it during the NT scan, we used to call them at 18 weeks. We've seen the invasion takes place completely by 22 weeks. So if 18 weeks it was positive, at that time they were not starting aspirin so early. So they used to say, come back at 22 weeks, if it's still persistent, we start on treatment. That was like 5-6 years ago or even earlier. Now gradually, as we've realized that aspirin is not going to help in the later portion, so that's why we're doing it in our NT scans. So the things have changed now. That was the dual screening policy for uterine Doppler many years ago. So that's how it has changed now. We're doing it in the first trimester, repeating it in the second trimester, it doesn't do any harm as such. Yeah.
Sir, in our anatomy classes, we've been taught that sometimes there are cases where one uterine artery is dominant, one uterine artery is non-dominant. What is the reflection on this? If we have to take the PI, sometimes we don't get a value on this, the contralateral uterine artery is sometimes not detected. I know I have been personally seeing this.
So have you tried vaginally then?
No.
So
see, honestly, I have never seen a case where one of the uterine arteries is not present as such, because if abdominally for any reason we're not able to see it, what I've seen is either we're not insonating the right vessel or we're not insonating at the right angle. That is always a problem. So just finish the rest of the scan, then come back, we invariably get it. Otherwise, do a vaginal scan, it never causes any problem.
The concept of dominant uterine artery doesn't exist now.
I don't know whether it exists or not.
No,
I have not faced it, Chief.
Yeah.
Maybe
No.
maybe more blood flow in one of the uterine, that is possible. Maybe possible.
Okay, fine. Another question, sir, the cutoff value is 1.5 in second trimester for
PI.
PI.
For the RI, I take a 0.55.
And for IUGR per se, with unilateral notching, the PI is 0.55.
No, you don't separate anything. There's just so when it is a screening test. A screening test means either you're screen positive or you're screen negative. So if you have a PI is raised, that lady is screen positive for developing preeclampsia at whatever the sensitivity is. That's it. It's either one or the other. So
See,
you don't have different clinical situations with alag-alag cutoffs.
That's what I showed. If there's a persistent or bilateral notching, yes. If one side the PI is 2, the other side it's 1, so the mean is going to be 1.5, which is fine, not a problem.
See, the end point is the lady and the baby. The end point is not the uterine artery.
And whenever in doubt, the best is repeat the scan after 2 weeks or 4 weeks. Just
That's true.
Thank you.
First of all, thank you, Anita, for considering me to speak something about Dopplers. 2015, we are doing all ultrasound and everything. We expect so many things from ultrasound machine to give you information about the fetus as well as from for the mother. The reason is this machine, and evaluation of the machine is really very vital. There was a time when in 1989, 90s, we could hardly see anything from on a machine. And 2015, in last two decades, everything, the entire scenario has changed. And this is possible because of the evolution of ultrasound machine. See, what I am going to discuss today is Doppler in multifetal pregnancy, particularly for second trimester, how to evaluate. The Doppler in multifetal pregnancy, you can do and you can follow it up only and only if you have got a master key of a chorionicity. If you know the chorionicity, then and then you can do the follow-up and you can evaluate these multifetal pregnancy. Unfortunately, still I see 80% of the report where chorionicity is not mentioned. That is a pitiable situation in India. 80% of the report they put it as a twin pregnancy of 18-week gestation. Say fetus 1 lies below, fetus 1 lies up, the second fetus lies on an upper segment, anterior placenta, that's it, finish, report is over. They will mention the biometry, they will detect, they'll put no anomalies found, everything, but they hardly report chorionicity, which is really very vital in managing these ladies, because the chorionicity plays a huge role. The reason is monochorionic pregnancy has got its own complications, and these complications are because of the placental communications or the vessels communication which are there either on the surface of the placenta or within the substance of the placenta. If you really see, because let us see this video first. Can you see this? It's a twin placenta, and here I have on your right side I have injected a green dye, and on the left hand side I have injected a red dye. If you see, this is a crater where no communications are there, but at this lower portion there are few vessels which are traversing from one end to the another end of the fetal cord. So these are the superficial communication of these both the placentas. Both the placenta means both fetal circulations, they are communicated, and because these placenta or there is a fetal communication of circulation which is there, it leads to so many complications. Let us presume this. Let us see this video now. The single placenta having these communications, there will be, if there is a bidirectional flow where the pressure is maintained in both the fetus, then there is no issue. The moment one fetus becomes donor and this becomes recipient, all the complications starts. This is one of the complications, CTTS. These fetus will be overloaded because of a high cardiac output, and high cardiac output will lead to increase in glomerular filtration rate that will produce more urine, enlarged bladder and polyhydramnios. Exactly the reverse thing happens into this fetus. Low cardiac output, low GFR, no Leica, no urine, no Leica. So that is the situation which ends up. This is only because of these communications. So if you understand these basic things, then you will understand how to utilize Doppler in various situations. There are multiple combinations of these vessels can be possible. One is there is arteriovenous communication, where one fetal artery is communicated to one of the fetal vein of other fetus. There could be these arterial communication. There are two kinds of arterial communication. One arterial communication is such that the vessel of the diameter is less than 2 millimeter, and another communication where these communication is more than 2 millimeter. More than 2 millimeter means there is a huge blood flow going from one end to the another end. And the third possible communication is veno-venous. The problems are less with veno-venous and arterial communication because at both the ends the pressure gradient is same. So there is very little blood which is going to go from one direction to the another direction. When the issue is there of an arteriovenous communication, because of there is a huge pressure difference, because arteries are always going to be a high pressure flow, it will throw the blood to the another fetus. So that baby becomes donor and another becomes recipient. The moment you have got arterial communication more than 2 millimeter, there again this pressure flow gradient is again major issue. So all in all, if you have got two situations are bad, one is arteriovenous and another is arterial more than 2 millimeter size. So that is how these anastomosis are very vital. Now let us presume one thing. It's one practical demonstration. You have got two, say, drums filled up with water. One is at this level, one is at that level. Is it going to make any difference in reducing or increasing level till they are communicated? It will remain like this. The moment you communicate them like a monochorionic twin, this is a dichorionic twin because they are all separated. Okay, placenta is separated, there is no communication. So there is no problem. The moment you are talking about monochorionic twin, there is a communication. The communication means what happens? The pressure gradient is going to be maintained. If this is maintained, again there are no issues. Okay, either that means there are many communications where equilibrium is maintained, established and maintained. So any one fetus is not going to be affected badly. The moment there are some issues where either because of the arteriovenous communication or arterial communication, the pressure goes up here, what will happen? This is going to push the blood here. Am I right? The pressure has gone up here. So in this sac, in this drum, it is going to push the blood into this drum. Am I right? So this situation will lead to what? Hypovolemic fetus and hypervolemic fetus. So this is a basic understanding about how the monochorionic twin pregnancies are going to behave. You are either dealing with hypervolemic or hypovolemic situation. To a great extent, if it is there, it will develop into the TTTS. If there is little bit of difference, you may end up in twin polycythemia sequence, anemia polycythemia sequence. So it is upon, it all depends upon what kind of pressure this segment is generating on one fetus will lead to clinical situations. In all, dichorionic pregnancy, both the fetus will behave as a single unit, but monochorionic fetus, because of a possible vascular connection, they will behave as a single unit. So that is the baseline difference. Now let us discuss monochorionic pregnancies first. Complications in monochorionic twin pregnancies, all in all complications are because of the discordance. All. In monochorionic complications, it could be discrepancy or discordance in the size, it could be discordance in middle cerebral artery Doppler, it could be discordance in the malformation or a trap sequence, or there could be differentiation discordance in the amniotic fluid. So all this leads to these different kind of situations: selective growth restriction, twin anemia polycythemia, midline anomalies and trap sequence, and twin to twin transfusion. All in all, remember one rule, that these pregnancies, monochorionic pregnancies, are to be scanned every 2 weekly interval. That too for biometry, amniotic fluid deepest pocket, uterine umbilical artery, middle cerebral artery peak systolic velocity, ductus venosus. Sometime we have to go for tricuspid regurgitation also, and definitely brain examination. Detailed CNS examination you have to carry it out. This is what you have to follow for all monochorionic twin pregnancies. One typical thing, let us discuss first thing first. It's a discordance in the size. A discordance in the size, where it is important is to identify whether it is type 1, type 2 or type 3 kind of discordance once it is established. We establish the twins discordant size by 20% of leg, or somebody says it could be a 25% of the leg of the difference in the fetal weight. Okay, so the type 1, where you find a uterine artery Doppler where only resistance is increased, which has got little bit favorable prognosis. Type 2, where there is a continuous kind of reversal or absent A wave, absent diastolic flow. The third pattern, which is the worst, is intermittent pattern of normal and intermittent pattern of reversal. Now, can somebody explain why this is happening like 2 is good and this is not good? Technically speaking, we always say that this is good and this is not good. Am I right? But in this case, it is little bit different. This is worse than this. The reason is, this is compensated. Tell me, umbilical artery Doppler, if you have got a waveform like this, which appears good as far as whatever you know at present, whether 2 is good or 3 is good.
3 is good. Generally, that's what we take.
3 is good or 2 is good? 3 should be good. For umbilical artery, it is 3 is good. Am I right? Yeah. Madam Chanchal, do you agree with them?
Because I know the paper. That's the worst.
That's the worst one. Because these are the arteries which indirectly suggest that these communications are larger than 2 mm arterial communications. This is the worst because sudden intrauterine death and perinatal outcome are bad with these communications, this kind of ultrasound findings of a uterine artery Doppler, I mean umbilical artery Doppler. No, that is not true for, I am talking about only and only monochorionic twin pregnancies. That's why it is different. It is not the same with a singleton. Dichorionic pregnancy, this is better, this is poorer. But monochorionic, this is worst, and so that is exactly other way around. So that's the difference between that. A word about discordance in the Doppler. You know that Doppler, how to take a middle cerebral artery Doppler parameter and put it into the Maris chart. How many of you really have a Maris chart, either photocopy or original Maris chart in your consulting room or under your table? 1, 2, 3, 4. Now 5. How to diagnose fetal anemia without Maris chart? Is it difficult, isn't it? Multiple? How? Maris chart चाहिए आपको. If you do not have Maris chart, one simple thumb rule. Thumb rule is whatever gestational age at which you are evaluating that lady, just double the value. If gestational age is 25 weeks, the moment MCA PSV crosses 50, that fetus is having moderate to severe anemia. It's a simple thumb rule. You do not require a Maris chart with you. But if you follow the simple thumb rule, you will know whether it is normal or it is abnormal. And the moment it is exactly at the same gestational age, MCA PSV matches that. What I mean is at 25 weeks, if MCA PSV is 25 only, it suggests 0.8 MOM. That may indirectly suggest you that there is a polycythemia. Now the reason why it alters. In anemia what happens? Why MCA PSV is higher and in polycythemia it drops down? What is the reason? Viscosity of the blood. Viscosity is more and viscosity is less. Now just I will take one example. If I have got one bucket full of water and another of oil, if I throw it at the same pace, which will go for water? Why? Less viscous. The anemic blood, which is really thinner, because RBCs are less, so the RBC movement is going to be faster. Because RBC movement is really very fast, you get MCA PSV 1.5 MOM, that is higher one. The moment the blood becomes thicker, there is no space for RBC to move, so MCA PSV will drop down to 0.8 MOM. So this is how, if you measure the MCA PSV, that is how you will be able to diagnose. How to diagnose, which are the stages? This is all again theory. I am not going into the detail of the theory, because you have to diagnose that the donor fetus will have less blood or more blood. Less is going to be anemic. So MCA PSV is going to be high, 1.5 MOM, and the recipient will have either normal or 0.8 MOM of middle cerebral peak systolic velocity. If you find these combination, please diagnose that this fetus is also suffering from discordance in middle cerebral artery peak systolic velocity. This is going to be an ultrasound appearance. This is anemic placenta or this is anemic placenta? The upper one or my side? Exactly. The upper one is normal placenta. This is thicker one, which is having anemic placenta, and it will have the fetus with like this, anemia with an polycythemia. And if you really see, the placenta is going to be very pale and this is going to be enlarged with very few communications. Here the crux is there are less or few communications between these placenta. So treatment is either you have to cut those communications or supply more blood to the anemic fetus. You can do either fetal blood transfusion or you can do laser to communicate, to cut the communication between both the placenta. This could happen either because after the laser, post-cord coagulation, this is possible. What you are supposed to do is something like either you have to supply the blood or do the fetal transfusion or apply or do the laser for these fetuses. Now discordance as far as strep is concerned, a situation where one fetus dies lead to hypovolemia, a sequence which is there. Let us understand one of the sequence. One baby is dying in utero and another fetus is normal. What happens just before the death of any human being? There is going to be severe hypotension. Am I right? Because that entire cardiovascular system is failing. Because there is sudden hypotension in that fetus, because of the communications, that pressure, that fetus pressure, fetal pressure is low. So the normal fetus will become donor fetus and push the blood into the dead fetus or about to die fetus. So these fetus which becomes donor, actually it is normal, will become suddenly anemic, will become convert into the donor fetus, and you will end up in a situation where either one of the fetus will die. Here the issue is the surviving fetus, because that fetus is already dead, but the surviving fetus, there are 30% chances of either neurological complications or cerebral palsy or even death of that fetus. So be aware of the situation, because 30%, even if the nuchal is 3 mm or 4 mm and the risk is 1 in 50, it is how many percentage? 2%. We are trying to discuss so many things. Even for the 2%, here the chances are 30%. You can understand the significance and situation of that fetus. So be aware of these kind of situation where either 25% fetus dies or there are 25% complications. Again, treatment is either you can transfuse that fetus or you can cut the communication between dead and the live fetus. Here again the crux is diagnosis of fetal anemia using middle circulatory peak systolic velocity. So all in all, about one word about twin-to-twin transfusion syndrome and how you can utilize Doppler there. Simple thing, a recipient and donor combination with 8 and 2, then and then you can diagnose TTTS. Role of Doppler in twin-to-twin transfusion syndrome, it is not about diagnosis of stage 1 and stage 2, because that is done only by grayscale. Fetal bladder present or absent, and Leica in the donor has to be 2 mm and recipient has to be 8 mm single largest pocket. That is how you diagnose TTTS, stage 1 and stage 2. But the moment you are talking about stage 3 and stage 4, where you would probably put your fetoscope in and do the laser or a cord coagulation to that fetus, that is diagnosed only by stage 3, thereby presence of end diastolic flow in umbilical artery in the fetus. Remember one thing, whenever you are evaluating multifetal pregnancy, taking an umbilical artery Doppler is always done at bladder level, not in the free loop. So remember this thing, do not sample the free loop in multifetal pregnancy. It has to be the bladder, because that is the only place where you are sure that these umbilical arteries of fetus 1 and another is of fetus 2. That is how the things are supposed to be. I'll skip some of the slides, because a word about laser or a word about cord coagulation. Now there are some controversies, and I always love controversies to be created and to be discussed out. Now multifetal pregnancy, twin-to-twin transfusion syndrome, should I use laser or should I use bipolar cord coagulation? What kind of modality, or shouldn't I touch that lady at all and let nature takes care? Everything has got its own advantage and disadvantage. The moment, see, it's exactly what counseling you do to that lady matters the most, and what are your concepts that matters the most. Because if I really say that, here it is mentioned that if I do a laser in twin-to-twin transfusion syndrome, still there are going to be 60% carry home baby rate with 20% of cerebral palsy. Okay, if I count, and the expense is 1 lakh of rupees or 1.5 lakh of rupees in Delhi. The moment I counsel a lady, देखो आपका 1.5 लाख रुपए का खर्चा होगा, 10 में से 6 बच्चे जिएंगे, 2 यहाँ से प्रॉब्लम वाला आएगा दिमागी रूप से, सिर्फ
हाँ 6 जिएंगे, 2 को प्रॉब्लम आएगा, 6 में से 2 नहीं, apart from out of this 2. So and the moment you counsel it like that, how many of the patient would you think that they will be agree for laser? None, right? And if you ask them for cord coagulation, that you are sacrificing one fetus and the cost is 15,000 rupees, but at least your one fetus will survive. So it is for Indian scenario, for European scenario, the things could be different because everything is paid by the NHS. So they say मैं तो आके सो गई, तुमको जो करना है कर लो, मेरे को जो हो सकता है करके दे दो. Am I right? That is how their approach is. Our approach is totally different. Patient has to think, we have to think 5 times, and probably we are thinking more for the patient. A patient बेचारा poor है, उसको कैसे करेगा? We do not know, still we are thinking like that. Right? Honestly speaking, that is what the situation is. And we will, and so many of the obstetrician will write to a radiologist, इसका 500 रुपये ही चार्ज लेना, patient बेचारा बहुत गरीब है. That is what is happening. We do not know exactly what their financial situation is, but this is the thing which we do not want to take any decision, but our job is to put everything in front of them so that they can decide. Again, this is a laser coagulation and bipolar cord coagulation which could be there. This is a bipolar simple procedure, not very difficult one, done in a local anesthesia. Insert your 3 mm ka trocar into the maternal abdomen, catch hold of the fetal cord and just coagulate. You will see the fumes, and after repeat this procedure at 3 places and your job is done. This is laser or even a laser cord coagulation, you can do it. It's a simple one, but let patient choose their way of management and be very open in counseling each and every aspect, right from the expense to the outcome. Make sure that you have explained them everything. Now one more important point, patient has come to you at 22, 23 or 26 week. Diagnosis of chorionicity is really an issue, am I right? So how to diagnose? A recent paper in 2012 come up, what they say that because of 2 different placenta, both the fetuses are behaving as a separate units, their PI value and RI values are going to be different. The moment you see the same PI and same RI value in both the fetus, consider them as a monochorionics. So this is how you can possibly predict, which is up to 90% you are correct. So this is one thing which you can remember, because diagnosis of chorionicity is difficult after 20 weeks or even after 16 weeks, it takes hell of a lot of time and efforts to diagnose the chorionicity. So that is how something it goes, right? So Doppler in MCDA, monochorionic diamniotic pregnancy, this is crux. As I told you, first time Doppler in the aneuploidy screening. Aneuploidy screening, ductus venosus is the best one as far as aneuploidy screening goes, and unfortunately the chorionicity is not mentioned in the ultrasound report. The software will never recognize, will never calculate it correctly unless you put in that it's a twin pregnancy and twin having monochorionic or twin having dichorionic. Unfortunately, when an obstetrician have a look at a twin pregnancy, they will start everything. Beta HCG, she is on beta HCG, she is on uterine relaxant, she is on X number of drugs. Am I right or wrong? Those who are doing obstetrics practice, right or wrong? Yes. So that is how, and that makes again biochemical screening more difficult. If I am examining a multifetal pregnancy, having normal nuchal, having normal ductus venosus, anyhow I have to do it for my monochorionic pregnancies also to find out a possible development of TTGTS and possible development of fetal growth restriction. That is really very vital. So that is where again it is going to be important. I am skipping some of the slides because this is, otherwise it will take, it won't finish this. Okay. As I told you, dichorionic, they will behave as a single unit. And for fetal hypoxic sequences, what everybody has to do is identify uteroplacental insufficiency by which Doppler? Uterine artery, like this. The moment you find there is increased impedance in umbilical artery, you will have increased PI value in umbilical artery, and that will lead to initiation of redistribution. Am I right? Now, why there is a redistribution? Why that happens? And who initiates? Which is the center which will initiate this redistribution? हम बोलते हैं ना brain sparing effect. That is arterial redistribution. Who initiates and why? Hypoxia. Hypoxia leads to what? But who is going to initiate? Somebody has to give a command. The hypoxia will to accumulation of CO2 and reduction in the pH value. That will initiate the centers in the midbrain and arch of the aorta, baroreceptors and chemoreceptors. They are stimulated. Once they are stimulated, they will send the signals to send more blood to the vital organs, not to the brain. It is the vital organs. Which are the vital organs? Renal, no. Which are the vital organs? Heart, brain or तीसरा? Adrenals. So unfortunately, adrenal artery and coronary arteries are so small that you will never be able to pick it up, that there is vasodilatation. That is the reason why we do middle cerebral artery, and it is exactly located at the base of the skull at one fixed point. You got it? Have you ever thought why we are doing MC only? This is the reason. Okay, it is reproducible, and you get, because you want to diagnose whether that initiation of baroreceptor and chemoreceptor, that stimulation is there or not. You got it? Once you find these baroreceptors and chemoreceptors has stimulated them to dilate, what happens? There is going to be reduction in middle cerebral artery, and there is going to be, if still situation worsens, then there is going to be reversal in the aortic isthmus. Okay, aortic isthmus Doppler is considered now as one of the best tool to evaluate fetal growth restricted fetuses, particularly with hypoxemic hypoxia. If we don't do anything, then there is going to be reversal or absence. Still, if we don't do anything, what is going to happen? Breaking down of this compensatory mechanism, which is initiated by baroreceptors and chemoreceptors, they are taken away because those cells are already dead. Because those cells are dead, the signals which they were sending to dilate, they are off. They are off. That means again the cerebral vessels are going to be showing constricted and showing normal flow, and that will lead to abnormal CCA, abnormal venous flow, congestive cardiac failure, and hypoxemic flow, how the fetus is going to react. So this is exactly how this fetus will react when they are monochorionic twin. I am not going to discuss all this. This is one recent concept of management of fetal growth restriction. This is what is known as a Barcelona. This is by I forgot his name. I forgot his name. I'll just tell you. Greta Kos. Greta Kos has come out with this idea, and I think in India we have to stop and we have to deliver at stage 2, because we cannot afford to call her every day, and with the possibility of fetal acidosis very high, right? So for us, this is the one where either uterine artery is absent in diastolic flow and reversal of aortic isthmus, then you have to deliver her. So carry home message. The important part of ultrasound in multifetal pregnancies are counting, numbering them, and precise chronicity. For MCPS dichronic, you can examine them once in a month, but in monochronic, you will have to do it twice in a month, every 15 days. All issues of monochronics are done because of the discordance between them. Watch out for the anomalies, serial growth, Doppler, largest pocket and cervical length. Twin pregnancy, impedance of uterine artery flow is going to be less, but there is no role in predicting preeclampsia. There is no role of uterine artery in prediction of preeclampsia as far as uterine artery goes. When you are evaluating for fetal anemia, please utilize these two charts, MCA PSV, Maris chart and uterine artery PI. When you are doing it for growth restriction and maternal hypertensive disorder, 4 charts, umbilical, mid-cerebral, ductus and uterine and aortic isthmus, 5 charts. Essential for TTTS chart, it could be umbilical artery, middle cerebral artery and ductus venosus. All of them are to be utilized. In the pregnancies with severe TTTS, there is increased umbilical artery PI in both recipient as well as in the donor. Then you have got the ductus venosus flow, which is going to, you have to monitor in both donor as well as recipient twin. In the donor fetus, the velocity across the AV valve is going to be reduced. Severe TTTS, it is said that once there is a severe TTTS, donor are consistent with decreased venous return due to hypovolemia and increased cardiac afterload due to increased placental resistance. That is what we have already discussed. In dichorionic diamniotic, DCDA twin, treat them as a single individuals. MCA twin at the time of 11-14 week, ductus PI is a good predictor for development of TTTS. Monochorionic twin at 11 to 14 week scan, discordance in CRL is a good predictor for fetal growth restriction. And MC twins, monochorionic twin in 2nd and 3rd trimester, uterine PI, umbilical PI, MCA PSV, ductus PI every 2 weeks. So that is how you have to manage them. Thank you very much. Now about the fetal anemia. What are the important causes for fetal anemia, how to evaluate this fetal anemia and how to treat this fetal anemia, that is what is important for us. Important causes, you know that which is listed in the books, which is there in all the books. Either you can have RH isotonization, that could be feto-maternal bleed, that could be because of the monochorionic twin which we have already seen, and the third could be the parvovirus B19 infection. So for me, first investigation is going to be blood group of the mother, right? If she is negative, I'll start thinking about isotonization, but otherwise rest of the 3. So that is how I'll start thinking. And what are the investigations you will probably ask, where you will find either fetal anemia? Indirect Coombs test, Klehor-Betke test, flow cytometers are not available still now in India. It's for as far as knowing the feto-maternal bleed is concerned. Okay, there are plenty of flow cytometers are there across India, but to know exactly what is a quantitative feto-maternal bleed, it is not available. So we have to rely only Klehor-Betke test. Then becomes middle cerebral artery peak systolic velocity. You could do invasive testing by getting blood directly to measure the hemoglobin. Look for the twin. Sometime what happens at 16-17 weeks, we are doing a scan, one fetus we have seen, but another stuck twin, sometime it's difficult to see, particularly in the obese women. When you find MCA PSV is high or there is polyhydramnios, please have one more detailed search on the periphery of the abdomen, because if it is lower down, you will be able to see that. But the moment it is 16, 17, 18 weeks with severe TTTS, the fetus is going to be stuck on one of the side. So please rotate your probe from one end to another end and try and search for another fetus which is hiding in a corner, right? Please search for this. You will sometime, even if you find these fetuses once in every 5 years, it is worth it, because otherwise it will take away all your credits which you have accumulated for last 5 years. जो भी आपको भेजेगा यार उसको 2 बच्चे थे वो भी पता नहीं चला. See, that is worst thing probably we would like to so one more important point is parvovirus, IgG, IgM and PCR of parvovirus. So these are the basic thing. Let us discuss straight away a clinical situation where mother is already isoimmunized, Rh negative mother, and you have got indirect Coombs test positive. If indirect Coombs test is negative, mother is not going to develop, that fetus is not going to develop anemia. So we are not worried. Here we are worried when there is antibody sensitized patient. Our worry is what? Whether baby is going to develop anemia or not. It is not necessary that all sensitized pregnancy, all fetuses are going to develop anemia. Am I right or wrong? Right or wrong? Right. Why? Amount of antibody. Is amount is more or something else is required? Do you know anything about the virulence of antibody? See, highly virulent antibody, even if sometime you will see that baby is anemic even in 1:64 ICT is positive. And sometime you may not find that baby becomes anemic even at 1:1024. The reason is the virulence of that antibody. Okay, higher the virulent antibody, more are the chances of baby developing fetal anemia. Okay, so that is one thing which I would like to stress upon. Another point, why it is like that is, if husband is, here you are dealing with positive husband, but the problem is husband could be homozygous or heterozygous Rh positive. If he is homozygous, then all fetuses are going to be Rh positive, and heterozygous, half of them. If let us consider he is homozygous positive, that means all fetuses are going to be Rh positive, but here if there is low count, low quantity of antibody having low virulence, this baby may not develop anemia. A high concentration of antibody with low virulence may develop anemia, but high virulence, high quantity will definitely develop. So that is the reason why you have got multiple combinations. Some patient will develop, some patient may not develop, some titer, yes they develop, but at the same titer another patient will not develop. So there are all multiple combinations. So idea is to diagnose husband's genotype and evaluate them accordingly. Here most important point is past obstetric history, that is very useful. The moment you see one fetus having either hydrops or one intrauterine fetal death, please predict before 4 to 6 weeks that baby has already started developing fetal anemia. So if that lady gives you a history that 6 mahine mein bachcha mar gaya, at 26 week that fetus has died, you need to start evaluating her right from 18 weeks, and you may have to transfuse that lady at 22 weeks. So last history where her past history is going to be very vital. You will have to follow her up every weekly if she has got previous affection, and you can do intraperitoneal transfusion as early as 18 weeks. It's a simple procedure, really simple one. I'll show it to you, but intravenous and intraperitoneal transfusion can be offered after 24 weeks, and it has to be repeated every 3 weeks till baby becomes mature and you are comfortable. It is not your comfort, it is your neonatologist colleagues' comfort you have to see for. If somebody is working in rural areas in Uttar Pradesh, they will not be comfortable till 35-36 weeks. You will have to continue transfusing that fetus. If you are working in Apollo, you are comfortable at 30-31 week. ठीक है, चलो इसको निकाल डालो, वो करेगा. So it is all, there are no fixed rules that you have to continue till 35 weeks, but the moment it's not your comfort, it is your neonatologist colleagues' comfort that okay, I am comfortable at 32 weeks, bring it out, I'll take care. But unfortunately, if there is some complications of fetal transfusion where baby dies at 34 weeks, keep the OT standby. Still there are issues that baby either will not tolerate or baby will die in utero. Fetal complication, tearing of the vein umbilical baby will bleed drastically and baby will die within 5-7 minutes. Do you think that in 10 minutes you will be able to deliver that baby in any setup? You will do transfusion in operation theatre, yes. Are you going to keep your anesthetic standby? We don't keep anesthetic standby for doing intrauterine transfusion. Do you keep?
After 32 weeks, we inform the theatre and do keep anesthetic.
If you do like that, your anesthetic is also standing there to induce, to put a pentothal straight away.
So that's because we're already a functional OT, it's not a problem.
So everybody does not have this luxury, right? So make sure that you make your neonatologist colleague comfortable and work it along. This is one flow chart which is, I think, is difficult to read. It's already there on my website. You can visit for this how to manage antenatally. It's in parasfetalmedicine.com. You can visit and you can have a look at it. Anemia in multifetal pregnancy, this is what we have already discussed, so I am not going into this detail about managing a fetal anemia in monochorionic pregnancies. But about parvovirus B19 infection. So many of us are already having parvovirus B19 infection during our childhood age or during any time of adolescence, and most of us are maybe harboring more than 50% of this parvovirus once in our lifetime. So we will find, you may find appearance of IgG antibodies in any of the mother, but inconsistent appearance of IgM probably confirms that there could be a reactivation or reinfection of this parvovirus infection. Fetal infection, you will have to do a chordosynthesis and get the fetal hemoglobin done, and positive PCR from amniotic fluid also is one of the clue to diagnose this parvovirus B19 infection. Out of, let us, as I told you, 50% of the women could have IgG antibodies in their circulation, and 2 to 10% could have seroconversion during pregnancy. Out of this, 30% can have fetal infection and 1% can have hydrops. Unfortunately, in India, most of us, diagnosis of parvovirus infection is done at this place, last stage. Am I right? She develops hydrops and suddenly we start thinking, "Arey, ye to she is B negative, B positive. Usko hydrops ko to kya hoga?" Am I right? So we diagnose only at this stage. So make sure that there are evaluation of by middle cerebral artery has to be done. A seroconversion, again fetal infection is totally a different topic, and because seroconversion is very vital in diagnosis of recent fetal infection and asking for whether should I investigate that fetus or not. The meaning of seroconversion is it is disappearance of IgM antibody and simultaneously either appearance or increase in IgG antibodies. Because the normal human response to one infection, primary response is what? IgM antibody will rise on the first go, and then it is going to reduce and it is going to be followed by IgG antibody elevation. So only IgM antibody could tell you that there could be a very recent infection, but it could be false IgM positive. Am I right? Let us pick up one situation where IgM is positive and IgG is negative. What does that suggest? False positive or recent infection. The moment you confirm a follow-up blood test after 3 to 4 weeks that IgM has gone down and IgG has gone up, what does that suggest? It confirms that that was an acute infection. But the moment even after 4 weeks the same report comes, that's a false positive. So seroconversion, confirming the fetal infection by seroconversion is most important to diagnose fetal anemia, any fetal infection, and fetus has to be evaluated exactly 5 weeks after this fetal infection has set in. So parvovirus infection will go to the heart, liver, lung, bone marrow, and this will lead to severe fetal anemia and sometime because of severe fetal anemia there is going to be high drops. 75% IUFD is going to be because there is no treatment, and 25 because of the treatment. I am just skipping some of the slides. Again, MCA PSV, doing a chordosynthesis and intrauterine transfusion is the key. I will show you, you can also have anemia will lead to cardiac dilatation, but the viremia to the heart will show you dilated heart with more bright echogenic heart. You will have sometime, because of this viral myocarditis, there is non-resolving high drops even after 3 to 4 weeks where MCA PSV is normal or you have transfused that fetus. This is the reason why you may end up in sometime this kind of non-resolving high drops. You can end up with a brain injury, and which is there. Now you have got all the possible pathologies. Now how to diagnose fetal anemia? Most important is middle cerebral artery peak systolic velocity. The reason is it has got at 95% confidence interval, likelihood ratio is 8.45 and the negative is 0.02. This line means that if MCA PSV is more than 1.5 MOM, putting up your diagnosis for moderate to severe anemia, you are correct by 95 times, 95% you are going to be correct, and you are going to be wrong only on 0.02 occasions. So that significant it is, and it is reproducible, and it is 98% accurate. So how you have to take is the simple one, do one thing. This is one still image. Middle cerebral artery has got two parts. One is part 1, this is straight just after the circle of Willis, and this is part 2 which is little bit curved. Put your gate of 2 millimeter just after the origin from middle cerebral this artery. So it is almost you are going to be in the middle of the first part of middle cerebral artery. There you have to put it, and whatever angle it is there you need to correct. Let us see the video there. Most ideal is this is the situation. If I get it exactly 90 degree, that is the best one. The moment I do not get exactly 90 degree, in that case what I am supposed to do is identify the base of the skull, see that this vessel is angled, then put your gate here, then rotate, just put it your yellow line parallel to this and put it on the vessel, that you are not confused at all, that you see that it is exactly parallel to it, and that is how you put it and trace it. After tracing this MCA PSV, just put it into Mari's chart. As I told you, double, I just confirm it again. If she is 30 weeks, then 60 is in the zone B, 25, 50 is in this group, 20, 40 is in this group. So zone B is suggestive of moderate to severe anemia. This thumb rule will probably help you in your day-to-day practice. Most important is, if she is, that child is, fetus is going to maintain the MCA PSV, I know that baby is not developing anemia. But the moment it starts following this route, I expect that in next visit probably baby is going to develop fetal anemia, and this is exactly the time when one should refer that fetus. One should refer that lady to an appropriate center who can do the intrauterine fetal transfusion. Method, again simple, two method, intrahepatic and intravascular, intraperitoneal and intravascular. Placental cord insertion is the best one, best place to put it across. How much amount of blood to be transfused? That is, you can utilize Astraya software or Viewpoint, or there is one transfusion coefficient value which is there. This is one transfusion coefficient value. If I expect the fetal hemoglobin to be around 5 grams, which is going to happen once the baby is going to develop high drops, and my point is to correct these fetal anemia till 15 gram of the fetus hemoglobin, right? So 15 minus 5, that becomes 10. And so remember this, write a 10 figure at somewhere else and expect your fetal hemoglobin, fetal weight, you know the fetal weight because you have already done the scanning. So multiply the fetal hemoglobin that where I have to increase the fetal hematocrit by 25%, multiply 0.05 by fetal weight, you get the amount of blood which is to be transfused. Okay. Now another one simple formula for intraperitoneal transfusion. If the gestational age is 25 weeks, subtract 20 from it and multiply it by 10. So 25 minus 20 becomes 5, 5 multiplied by 10 becomes 50. Transfuse 50 ml of blood into the fetal abdomen having fetal hematocrit value of around 19 to 20 grams of fetal hemoglobin. Simple. See the video. Now the issue here is, one important point is, such a huge surface, such a huge fetal surface is available. This is my needle which is already in. I have to put it here and just infuse the blood. It's simple, right? Because the issue with the intrauterine, intravascular fetal transfusion is, my target is, what is my target? 4 millimeter. Intravenous diameter is how much? Umbilical vein diameter is how much? 4 to 5 or 6 mm. That is my target. The moment I put it to intraperitoneal transfusion, fetal abdomen is huge, right? If I want to throw this on this side of the hall, I can easily throw it. The moment I want to throw it at Dr. Varun, it becomes a little bit difficult, right? So that is the reason intraperitoneal is going to be easier. It's simple. Now fetal transfusion. This is one MC I have done. I have diagnosed baby is having anemia. Okay. Then what I will do is simple. If you are lucky to have the anterior placenta and cord is like this, this is the needle which is coming here. This is the place the needle is. It is coming. Can you see the needle there? So that is the needle. Just go there with a sharp thrust. Go in. Yes. You are in the umbilical vein, withdraw the stellate, withdraw the blood. This is where we have taken the blood for fetal investigations. Apply a 3-way stopcock, and your colleague is pushing the blood with the syringe. It has to be pushed with the syringe because hemoglobin is 19-20 gram. It is not going to go by drop. So this is one way. Then withdraw again from the bag, rotate the stopcock, 3-way stopcock, and push it into the fetus. This is how you have to push the blood till you have completed the transfusion. This is how it is going to be appearing, because the moment you are pushing the blood, the velocity is going to go high, and because they are adult RBC, will be seen very separately, like how it is seen in an ultrasound. Okay, that is one way. That is how you do it with the anterior placenta. The moment it becomes posterior placenta, it becomes a little bit more difficult, and you put in your needle like this, and you are in the umbilical vein, and following the same procedure, same thing. If you find, sometime you find it difficult, you don't have anterior placenta or posterior placenta, you can utilize the free loop like this. This is one of the most difficult to perform. Or else, sometime if you are lucky enough to get the hepatic vein in front of you like this, you can even put your needle into the straight away into that vein and push your blood right there. So 4 places you can put the blood inside the fetal circulation. It's not difficult. The moment you remove the needle, this is the needle in, the moment I remove it, you will find this jet of the blood coming out from the umbilical cord, and see after a couple of minutes that it has stopped or it hasn't stopped. So that is how I can perform the fetal transfusion. Problems could be an angle, could be sometime the fetal movement, or sometime you can find the notorious. See this, the baby is already having ascites. Now at present I am doing the transfusion, everything is going smooth. Okay, am I right? And suddenly baby tries to grab the needle. You will see he is going to hit the needle also. This is the hand, and it will suddenly start hitting the needle. Can you see that? That is also possible. So everything is possible, be prepared. Sometime everything is going smooth. For 10 minutes the transfusion is going very smoothly, and on 11th minute you end up with this. So this could be possible, and that's the reason why I ask you. Sometime if you are doing in a free loop, it is going to tear the complete umbilical vein. So these are the difficulties: obesity, abdominal scar, blah blah blah. Could be these are the issues. Placental localization and friendly fetus. These are the two most important points in doing this. We have already done more than 350 transfusions, and with 80% of success rate. Last year we have published one paper in ISUOG where we have increased the target value of fetal hemoglobin from 45 to 55% by reducing 25% of complications. So that is what we had done it. So MCA PSV Doppler is going to be the best, and that is how you have to follow them up. Thank you very much.
See, I tell you, if there is an anterior placenta and needle, you are with an anterior placenta, it's not required. Where your needle is threaded at least 1 centimeter inside the cord, nothing is required. The moment you are not confident that okay, needle may come out, baby may disturb, for your safety you can give it, but it has got its own complications also. So try and
that's the SOP stand. That's this. This lady is second gravida, para 1, previous one, full-term normal vaginal delivery. That baby is doing well. This is a spontaneously conceived monochorionic diamniotic twin pregnancy at 27 weeks of gestation.
We're looking at a cardiac activity on one side. This will come? No. I can otherwise yell also, that's not a problem. That's cardiac activity of one. We're looking at, that's a cardiac activity on the other side. So we're looking at these two fetuses over there, both the cranii. So always have a general survey rather than first straight away labeling into whether it's a monochorionic or dichorionic. They've already told us, but first always check in for the cardiac activity of both the fetuses. Looking at the presentations, we're looking at over there. We're looking at the cervical length. We need a little bit of a bladder to be full, otherwise the gold standard would always be to do a transvaginal scan. We're looking at the placenta over there. And if you see over here, we have a gap in the placenta. So we're looking at one placenta which is right anterior. There's another placenta which is left anterior over there. We're looking in at an intraamniotic membrane. Is this a dichorionic diamniotic or it's monochorionic? Okay. So we're looking at, that's the fusion over there. And this monochorionic has been documented since the beginning?
Yes.
Okay. So we're first looking at the survey over there of the fetus. I'm still getting used to the machine. We'll just increase the grayscale over there. That's the cranium over there that we're looking at. We're looking in at the fetal face over there. Again, depends on what sort of an equipment resolution one is using. We're looking at the spine. We're looking at the heart over there. Always have a general survey. We're looking at plenty of movements. We're looking at a cardiac 4-chamber view. Can we zoom from here? Yeah. I have to press it, okay. We're looking at a nice cardiac 4-chamber view. Whatever we can basically see, whatever we can best see, I'm just going to try and demonstrate that to you. We're looking at the two ventricles. We're looking at the two atria over there. Measurement किससे चलते चलते measurement किससे ले सकते, so that I can have an arrow. नहीं इसे तो फ्रीज हो जाती है. कोई ऐसी चीज जिससे चलती रहे so that then I can have a cursor or something. क्या चीज़ है जी? We have a cursor. Perfect जी. We found a marker at last. So we're looking at both the ventricles over there. We're looking at both the atria over there. We're looking at, that's the spine. So we know we're looking at a left atrium. We're looking at the right ventricle with that moderator band. We're looking at a nice triple vessel view. We're looking at the right ventricular outflow tract, that's the pulmonary artery, that's the aorta, that's the superior vena cava over there. Cursor nahi dekh raha? Acha, this cursor is only for me, ji. You people are not going to be seeing it. So can we have a pointer over there so that somebody can just keep on pointing? Arrow hai nahi ji. Koi baat nahi, that's fine. And one always has to be careful whenever you're doing your detailed scanning, just looking at a cardiac 4-chamber view. Just try and assess. We're looking at the fetal stomach over there. We're looking at the cardiac apex over there. That's the axis. So we know this is all fine. You just need to tilt your transducer onto the ventricle towards the fetal shoulder. You go on the other side. Again, you'll be able to look in at both the ventricular outflow tracts crisscrossing nicely. You just go a little up and you'll be able to see a nice triple vessel view. You just go a little above and you'll be able to see a trachea view as well. We're looking at over there. So that's basically 2 extra minutes and you've been able to see so much about the fetal heart over there. We're looking at the fetal heart, the fetal stomach over there. We're looking at the fetal bladder. We're looking at fetal kidneys. And just a general survey of the, how do we go ahead from the zoom? That's perfect. Then we like to look in at the skeletal portion over there. We're looking at both the feet and we're supposed to be looking at both the hands. That's a nice namaste to everybody over there, Jay. Lovely. So now we start on with the Dopplers. So we start on with the umbilical artery. They've already scared me about Dopplers are going to be coming with difficulty. So that's why I thought let me just show you a little bit of the 2D as well. Dr. Chanchal has already scared me about it. There we're looking at the umbilical artery. Hanji. How do we do this? This is okay, fine. Just hold on. Just hold on. We're trying to look in at, I think so the sample gate is also too big. Thoda sa zoom karo ji, isko color box ko thoda sa bada karo ji. This is too small. हाँ अभी दिखाते हैं सर, पहले फ्री लूप से तो शुरू करें ना सर. क्या करना सर? मिडिल साइड ब्लैडर दिखाना पहले, क्या दिखाना?
नहीं, सबसे पहले ब्लैडर के बाजू में लेने को दिखा दीजिए.
अच्छा. We looking at those are the hypogastric arteries over there. We're looking in at the fetal bladder. आप दिखाओ जी इसको. ये वाली hypogastric arteries, that's the fetus moving over there. चलिए करो जी करो. ये simultaneous नहीं हो सकता जी. अच्छा कोई बात नहीं, अभी भी इसको ऐसे करते हैं. फिर से एंटर कर दें. That's the umbilical artery over there. We're looking at diastolic flow. We're looking at systolic flow over there. Again, depending on fetal movements. So we're looking at both the. We're looking in at the urinary bladder. We're looking at both the hypogastric arteries. So that's the best way. Otherwise, in a singleton pregnancy, we would be looking at a free loop, depending on how you're looking at the umbilical arteries. Again, depending on, it's always better because if you're getting confused whether you're looking at this side's umbilical artery or not, but if you're looking at a proper intraamniotic membrane, if you're looking at a proper intraamniotic membrane, you know on this side, that's the right side, you're looking at this side's umbilical cord, and if you come onto this side, you're looking at this side's umbilical cord. So depending on what you're comfortable with, ideal way so that you're not confused is the best is that you're looking at the hypogastric arteries. प्रशांत सर, आपने बताया ट्विंस में और क्या क्या दिखाना है सर?
सर जी हमें उनको एक MCAPS भी दिखा दो और दिखा दो.
Color. Then we're looking at the middle cerebral artery over there. इंसोनेट करो जी, यहाँ पास में करिएगा जी.
So did everybody notice how Dr. Kuldeep brought the MCA as close in line with the vertical as possible? He just moved his probe sideways so that the angle of insonation is as close to 0 as possible.
One has to realize either the fetus is going to be moving, otherwise what you have in your hand is, you can move the probe or you can tilt your patient, but you cannot do anything about the fetus. So you are at the mercy of the fetus, so always be careful on that. So you
show me the angle correction कहाँ से angle correction जैसे change होता है MCPSV कैसे change होता है?
Basically, why have we started using the systolic diastolic ratios, the RI and the PIs is because the velocities are always dependent on angle correction. So if you're looking at a peak systolic velocity in the middle cerebral artery, to say whether this is anemia or not anemia, we need a proper angle correction, because if you're going to change the angle correction, please change the angle correction in this.
Put it, right now if you can see on the screen, the MCA PSV value is 39, okay, and the line is like this, am I right? Now let us change that angle. Can you please correct the angle? Exact 90 degree कर दो इसका. करो और करो. Okay, no, इसका 90 parallel to this yellow line. Or, okay. So that 39 has become 37, and still if you change that, this is going to 49. So it is the entire peak systolic velocity is going to be altered, is not going to be correct, and your diagnosis of fetal anemia is not going to be correct. So that angle correction is basically required.
Angle कहाँ से change हो रहा है?
See that the PI and RI values are not changing. If I change the angle, it is only the peak systolic velocity which is changing. It is not the PI and RI value. So for hypoxic evaluation, the change of angle may not be required. But to diagnose anemia, that is necessity.
If you see over here, on the side what is happening is, the waveform remains the same, but on the side if you see where the table is, there, you can see just where your peak is. Now you're getting an 80, you're getting 60, you're getting 100, so obviously those values are going to change. So that's where the angle is really helpful. So you have to be careful that you're using a proper angle.
Correction allowed is not more than, honestly speaking, 10 degree. Technically in the books it is written 30 degree, but for fetal anemia diagnosis is only maximum 10 degree.
We're looking at, now that's the ductus venosus over there that we're looking at. ये क्या हुआ जी, चालू क्यों हो गया? हाँ, this is there. That is what you.
छोले भटूरे खाना है.
Yeah.
मशीन को खिलाओ छोले भटूरे. चाइनीज है.
Indian है.
हाँ जी, करो. Just hold on. We're looking at, that's the ductus venosus, we're looking at the umbilical vein coming inside. The moment it changes color, that's where I normally look in for the ductus venosus. Can we remove the
Color box.
insonation? Just color box रहने दो जी. Ductus venosus being an extremely small vessel, and with the fetus moving, one has to be extremely careful. We're just trying a little harder. Lisa, I'm always comfortable on the transverse.
Me too. Make a massage.
You see the complete length.
If I take a sage over there, that's where the ductus venosus is. Basically, it's a 2 to 7 millimeter vessel, so always gives a trouble G, and especially if you're using a new machine with the fetus moving, always a little difficult. But that's the portion, this is where the ductus venosus is. We can always try and see if we can figure it out in the other one. Anything else, Prashant sir, जो दिखाना है इसमें, twins में?
नहीं sir जी, basically 3 vessel Doppler, mid-cerebral, umbilical and ductus venosus. Now tell me why there is
ये देखिए कि monochorionic है तो every 2 weeks we have to document all 3 Dopplers, bladders in both settings, and the AC
unique. Something really very unique. If you what is going to happen? The target is here. It is the maximum oxygen which is there in the umbilical vein. Am I right? That has to go to the upper part of the body, because the aorta is going to supply to the coronaries. There is a first branch from ascending aorta, and brain will get from the arch of the aorta. So the crux is the blood in the left ventricle has to be very highly oxygenated. Okay, the moment the regular in our circulation, left heart is having high oxygenation because of the lungs. Here there is no lung, there is no circulation from the lung, and there is no oxygenation from the lung. So nature has created one jet which arises from ductus venosus, and it is directed towards the foramen of oval. Okay, if the blood flows just like inferior vena cava with a regular velocity, is going to mixed up, and in right atrium is going to be the maximum oxygen. Then some part will go to right ventricle, and then something like that. Instead of that, creating a small jet has directed the complete oxygenated blood to the left atrium. From there is going to be the left ventricle, and from there is going to be entire upper circulation. At the moment you have got CCF or failure in the heart, what happens? The right heart, sided heart is going to be failing. Right atrium will have higher the pressure. Higher the pressure is going to be reflected into the atrial contraction. So that indirectly this is going to press or create resistance in the ductus venosus. That is the reason there is going to be a reversal or a dip in the ductus venosus. So it's all about nature's, what is body's requirement? Nature has created simple one thing, just narrowed down the diameter of umbilical vein, and entire situation is different. The moment that vessels opens up, the blood will not go to the brain, and it is going to be mixed up, and that will end up in a hypoxia. Am I right? So that is the important, and because it is narrow, it is going to create aliasing. Because समझ लो पानी एक बड़े नाले में से जा रहा है, वहां से एकदम छोटा नाला हो जाता है suddenly, तो वहां पे क्या होता है? There is a turbulence, and these exactly turbulence which is happening in ductus venosus, and that is what we try to identify as an aliasing effect.
Dr. Prashant, we'll just quickly finish with the patient. Sure. We just want to highlight that there are 3 images. I have them. In a monochorionic twin pregnancy, one must actively look for signs of twin-twin transfusion syndrome, especially from 16 to 26 weeks. And that's why the 2-weekly surveillance is important. So in every scan, we must document that bladders of both twins are seen. We must insonate all 3 vessels and document Dopplers at all gestation starting from 16 weeks. So the umbilical, MCA and ductus venosus has already been shown by Dr. Kuldeep. We have stored an image showing bladder of both the fetuses, and the 3rd image is showing both the ACs. These 2 kids, there is a slight weight difference, but it is less than 10% as of now. And since she is already 27 weeks, we are hoping that the time that twin-twin transfusion would have occurred is gone by. So these 3 images must be stored for every monochorionic twin pregnancy.
We have another twin pregnancy after this? Yeah. Ujjayi, paid post लीजिए, Ujjayi. बस हो क्या चलें Dr. Prashant is feeling very hungry. Let's have lunch.
It's not about me feeling hungry, but पीछे के जितने भी talks are really got delayed. From here to Leela Gurgaon will take another 2 hours in the evening. So we want to finish in the time. I tell you, lowest is the whatever you don't find any aliasing is the best one. BRF could you can do it as low as possible. There is no fixed rule. You have to do it 5.6 or 2.1 or 2.5. Put it at that. It it all depends upon actually the habitus of. Okay, but filter. Laser is only solution. Then, but only issue is if I do the laser, I have lost in everything goes. What resolution is acceptable. That has to be acceptable to the cup. उनके पास जेब में कितना है आपको पता नहीं.